Yes, ma'am, we are live now.
Yeah. So, good evening, everybody. On behalf of Oxy and Oxy Endocrinology Committee, I would like to welcome you all for our webinar on PCOS, the multiple facet of it. So, as we know, PCOS is a very, very enigmatic disease with multiple facets. So, we are going to look at the various other aspects of PCOS, which is generally not discussed in most of their meeting. So, it is going to be one of a very interesting webinar. So, I look forward for a very interactive webinar from all the faculty and delegates. So to start with, next slide, please. May I request our President, Dr. Jayarani Kamaraj, to deliver the welcome address, please. Jayarani Kamaraj, Madam, is the President of Oxy, a very, very vibrant and enthusiastic gynecologist, and she is heading our association, and she has a keen interest on academics as well, and she has developed these various committees to make sure that everyone gets involved in Oxy, and we are able to carry forward the work of Oxy to greater heights. So over to Jayarani, Madam.
Good evening, dear friends. Thank you, Mala, for the nice introduction. It gives me a great pleasure and honor to welcome you all for this Oxy webinar. Every month on the third Tuesday, we are conducting one webinar. And this time, Mala has taken it up with the Endocrinology Committee to have this session, which is supposed to have, be on the last month of this PCOS month. But because of some constraints, we could have it on October. This is a very important topic, as rightly pointed out by Mala. That's a multifaceted features of PCOS we all know, and we come across a lot of difficulties when we manage a PCOS women, almost right from the adolescence to the menopause. We have so much of problems we face with PCOS, and today Mala has taken up a good initiative to show all the aspects of the PCOS, right from the pathophysiology and the metabolic changes, and also about the fertility, and also the gut biosis, and all the lifestyle changes which should have all important aspects, which is very practically applied in the clinical practice. She has made a very wonderful preparation of the topics, and for this we have the great doyens and senior faculties. Dr. Madhubhashini Madam, we welcome you on behalf of Oxy and Oxy Endocrinology Committee. I welcome you. And we have the national figure, Dr. Ritu Khanna, who is very cheerful and a very dynamic academician. We welcome you, Dr. Ritu, for our webinar. And we have a lot of senior faculties here, Dr. Pushpa Madam, Dr. Shanti Singh Madam, Dr. Shiva Singh, and Dr. Roshni, and Dr. Sharanya, and all with our Oxy senior faculties and all my EC members. I, on behalf of Oxy, welcome you all for this webinar, and a very special thanks to Sheet for giving us this wonderful platform, and a special thanks to Chitrakala and Sahiti for coordinating it in a wonderful way. We welcome you all for this webinar. Over to you, Mala.
Yeah. So may I request our Honorary Secretary, Dr. Kundavi Shankar, to deliver the Oxy prayer, please. She is a very renowned infertility specialist from MMM, and is also running various fellowship programs and very keen in academics. Can you please deliver the Oxy prayer, please?
Thank you, Mala. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, Dr. Kundavi. So we seek the blessing of the Almighty for the safe conduct of this webinar.
Yeah.
We light the sacred lamp and illuminate the darkness of ignorance and light the lamp of knowledge. Can we have the lighting of the lamp, please? So I take the pleasure in inviting our chairpersons, Dr. Pushpalata Barua Madam, Dr. Usha Rani Madam, Dr. Dhanalakshmi Madam, Dr. Shanti Gunasingh Madam, and our junior colleagues, Dr. Shiva Singh, Dr. Sharanya, and Dr. Roshni. So may I request Dr. Pushpa Barua Madam to introduce our first speaker, Dr. Mridubhashini Madam. Dr. Pushpa Lata Madam is the professor and senior consultant of Ramchandra Medical College. She has a teaching experience of more than 30 years, and her special interest is mainly high-risk pregnancy, recurrent pregnancy loss, and also gynec endocrinology. So in fact, this is one of our favorite topics. So that's what Pushpalata Madam came to my mind first when I thought about endocrinology and PCOS. So over to Dr. Pushpalata Madam to introduce Dr. Mridubhashini Madam.
Good evening, everybody. Thank you very much. Yeah, I am very much interested in PCOS. Okay. Madam Mridubhashini, good evening. I don't know whether you remember me, but I remember you very well. I think we met personally about almost 20-25 years back. What strikes Madam Mridubhashini is her empathy towards patients and ethical practice. That's what stands out to me. I mean, I remember when you used to see patients along with us and used to demonstrate and all that. So that has stayed with me all these years. And of course, your knowledge is, everybody knows that she is in full command of endocrinology, fertility, and she's at the helm of all these endocrine issues. So we are very, very proud and very happy to have you here deliver this metabolic and other aspects of PCOS. Ma'am, we welcome you for this.
Thank you. Thank you. I hope everybody can hear me. Am I audible?
Yeah, very
Yes,
well.
ma'am. Yes, ma'am. Yes, ma'am.
It's such an honor for me, and I'm so happy to be back with the Oxy crowd, which I haven't been for a long period of time. Such a pleasure to see all those young and bright faces in front of me. So I'm happy to be with you this evening. And I think it's a wonderful topic that you've chosen. You know, it's always confusing, the multiple facets of PCOS. What are these facets and why are they different from each other? And it's always confusing to look at the basic pathophysiology. I know fully well that the basic pathophysiology is something that you don't want to think about in majority of situations. But understanding that in polycystic ovary sort of makes it a little bit easier to understand why it's got so many different facets. The changes are with you, right? Can you change? Yeah. It's one of the most common endocrine disorders in women. And this is a very old slide where it says about 5 to 10% of the population. There's been a recent publication in one of the leading journals. It's a multi-center publication from all over the world. And we were one of the centers that were representing in India. It's far higher in India. It's far higher in South Asian countries. And in some of the countries in South Asia, it's reaching up to 20-25% of population that checks into a fertility clinic. It's not the general population, but when a population of infertile women check into the infertility clinic, when you screen them, a large percentage of them have this disorder. Next. And what makes a PCOS, okay? And it is very different from other inherited genetic disorder. It's called a two-hit model in which there is one or more genetic traits. It's not a single gene disorder. There are many genes which are involved in this, and it's one or more of these genetic traits interact with one or more epigenetic, congenital, and or environmental factors. So many factors in a particular individual that go to make an individual a PCOS. Part of it is genetic, and part of it is what they have experienced through life, from intrauterine to outside to congenital and other environmental factors as well. But you need more than one factor to make a PCOS a PCOS. Next, please. And these epigenetic stages actually start in the intrauterine life of a female child who happens to have inherited these particular genes, one or more of them. It starts in utero. If the mother is PCOS, then that hormonal environment makes the child much more likely to be. Postnatally, the underweight children, the Barker's hypothesis, the underweight children turn out to be more likely to experience this later in life. The overweight children also tend to experience it much more in life. And more than any other phase in life, adolescence is one of the key phases. And we always wonder what happens in adolescence. Why does nothing manifest at birth and you don't see any change in a child or when it's growing up? And suddenly something seems to change when this female child, it's adolescence. And actually in every female child, we are not very sure how and why adolescence happens, what happens for the sudden changes in her body to happen. Next. So part of this, as we said, is genetic. 20 to 40% of female first-degree relatives have the syndrome, heritable and clusters in families. It can be single gene. It can be autosomal dominant, but majority of multiple genes. And this child then gets exposed to intrauterine exposure to androgens, particularly from the mother, because of her hormonal status, makes it much more likely that this child will get it. And early childhood, if it's too obese or too skinny, either one of them will make the child much more likely. A sedentary lifestyle in the early ages, environments, BPA, and androgen disrupting chemicals, which we are facing in every walk of our life, everywhere, is another thing that can do that. Obesity is much more than so. It doesn't actually cause PCOS, but it can contribute to an individual who already carries the genes becoming a PCO, manifest the PCOS. Next. So this is one of the newer things that has come about, the kisspeptin metabolism. Most of us who did our earlier studies have never heard about kisspeptin. It's a fairly recent area of hypothalamus. It's upstream from hypothalamus. It's upstream from hypothalamus and controls the hypothalamus. And this kisspeptin metabolism is now talked about. Kisspeptin neurons are also talked about in many situations, from this to even menopause and such things that happen in the hypothalamus, where it controls the pituitary and ovarian axis. It controls the entire axis. But what happens is it's almost like a juvenile break. It doesn't wake up until this kisspeptin metabolism only kicks in at puberty, and it's called a juvenile break until then, and a pubertal accelerator at that time. It starts working on the hypothalamus and the pituitary. But what happens is when it starts, it particularly concentrates on LH rather than FSH. So the two things that come out of the pituitary are FSH and LH. FSH, the proportion of FSH and LH under these young women who have the genetic tendency, the proportion changes. Proportion changes in such a way that the FSH is lesser than usual and the LH is higher than usual. So the ratio between FSH and LH changes. Next. And when that happens at the programming in puberty, there is an awakening of the hypothalamic pituitary axis, and two main things happen. It's the growth hormone and LH that come from pituitary. And the growth hormone actually starts the androgen production from adrenals, and in a way from the ovaries as well. FSH and LH changing ratio. LH, you would know that LH works on the cells in the ovary that make androgens, And FSH is primarily responsible for estrogens. So the ratio between estrogens and androgens changes as well. So it becomes an LH dominant and androgen dominant individual, because this change starts at the hypothalamic pituitary axis, and above that, the kisspeptin area. Another thing that happens is the growth hormone increases the insulin, and increases the insulin by a peripheral mechanism on the peripheral cells, where the glucose is blocked from entering the cells by two different mechanisms. One is inositol mechanism, another one is tyrosine mechanism. Tyrosine mechanism is decreased, and both ways the glucose does not enter the cell, and when the glucose does not enter the peripheral cells, the pituitary, the pancreas starts secreting more insulin. So there is two things that are happening. One is a hyperandrogenemia, another one is a hyperinsulinemia. And if you want the two terminologies which are the reason for all of PCOS, is hyperandrogenemia and hyperinsulinemia. Androgen levels go up and insulin levels go up, but it doesn't do the same thing in every PCOS. The ratio is different. So depending on the ratio, you've got a PCOS becoming more hyperandrogenic or more hyperinsulinemic. Symptoms vary depending on that, and the individual behaves differently depending on that. So the key two things that one has to remember is insulin and androgen. Next, please. Just keep on going, please. So the theca cells is where all this happens in the ovary under the influence of the gonadotropins. So primarily what you have to remember is FSH goes down, LH goes up, androgens go up, and estrogens go down. Next, please. Keep going, please. Okay. So insulin resistance and hyperandrogenemia are the two key things that make an individual into a full-blown PCOS, and it can be a hyperandrogenic individual or a hyperinsulinemic individual or something in between as well. Both are possible. Next, please. And in the periphery, what happens is, in the peripheral mechanism, central mechanism is kisspeptin mechanism that we talked about. Peripheral mechanism is at the cell level in the muscles and stuff. And what happens is that tyrosine phosphorylation can change to serine phosphorylation, which doesn't allow the glucose to enter the cell, and the insulin level goes up. Next. And this is the myoinositol, decyroinositol role in glucose uptake. Again, the same thing happens. Glucose doesn't enter the cell, and hyperinsulinemia happens when there's a deficiency of these as well. Next. And this insulin resistance in the periphery is what gives rise to the hyperinsulinemia. Hyperinsulinemia then is responsible for a lot of things that happen in this young child's body. The ovary secretes more androgens, the liver secretes less binding globulin, so the peripheral level of androgens go up, adrenals put out more androgens, and free fatty acids come more from the adipose tissue. So almost every cell in the body changes in response to this hyperandrogenemia and hyperinsulinemia. Next. And this is what you see when the hyperandrogenemia is much more dominant: irregular menses, acne in the face, hirsutism, obesity, acanthosis, hair loss, and such. Next. And insulin resistance can be a clinical diagnosis. A lot of people think that you have to measure the insulin or even do a GTT, but it can be very much a clinical diagnosis. When you see these acanthosis nigricans in a sort of an overweight child around the axilla, around the neck, you know that the child has insulin resistance. Skin tags, a lot of people don't look for skin tags, but skin tags also can be a marker of hyperinsulinemia. Next. And this also then has this these have an effect on the ovarian reserve. And ovarian reserve changes in the PCOS. We know, such as that to IVF, know that the ovarian reserve goes sky high, which means the number of follicles in the ovary becomes very high. And how does that happen? We've got to understand that the total ovarian reserve in any individual consists of two different groups. One is non-growing follicle, another one is growing follicle. The majority of follicles in a woman's ovary are non-growing follicles. We carry millions of them at birth, and it keeps decreasing to about 400 or so at menopause. And every cycle we lose thousands of them. But what happens with every cycle? Next. See that those are the primordial follicles. There is no way you can find out in any woman how much of primordial follicle she has. So the reserve in that area, we are still today incapable of clinically finding out how much of primordial follicles are there in an ovary. What we find out are just the growing follicles in the next thing. Each cycle, we think that 1 or 2 follicles grow, or even 6 or 7, depending on what the scans that you're doing. But actually, the primordial follicles have to go to something like 100 days or 120 days to become a mature follicle, pre-ovulatory follicles, and then release. Next, please. So primordial follicles, then primary, secondary, and small antral, then dominant follicle, ovulatory. What you and I see when we're doing an ultrasound is on the right side of this chart, starting from the small antral follicle, 2 to 5. The majority of the non-growing follicles we are incapable of seeing or finding out with any laboratory testing. But this phase, we have to understand, is actually controlled not by gonadotrophins. It's controlled only by 2 things. One is androgens, another one is insulin. Okay. And therefore, this paracrine control, when an individual has either more androgens or more insulin, this conversion from primordial to small antral happens much more rapidly, and much more follicles are recruited into the sensitive phase, the phase that we can control the growth further. That is the small antral phase. So when you're doing a scan for an antral follicle count, it's day 2 or day 3 of the cycle, what we see all these small antral follicles. And anybody who's floating around with a lot of insulin and a lot of androgen is definitely going to convert more primordial into more small antral follicles. So this is one of my favorite charts to show to teach residents, because when you remember this, a lot of sense you can make out of PCOS. Okay, the reason why they have a high AFC and a high AMH is because both these are, and in our ultrasound we can count them. AMH is secreted by the small antral follicles. So that is what gives us the actual ovarian reserve that we are talking about, which is only the second half, which is the 14 days out of this 100 days that we can have some control, because this is the phase that we can control with gonadotrophins. Next. So what happens clinically? This individual has got more androgens, more insulin, and she's got so many follicles floating around in the ovary. And what happens clinically because of all that? When you have that many follicles sitting in the ovary, the ovarian volume goes up, antral follicle count goes up, and in adolescence, the ovulation does not happen. Okay, and there's menstrual disturbances. So I'll concentrate on adolescence for the second half of this talk. Amenorrhea, very irregular heavy bleeding, oligomenorrhea. These are the things that these children present to us with. And if androgenization is more dominant, they come to you with hirsutism, alopecia, or acne. Obesity may happen in any one of these individuals. And generally, though, the virilized group is skinny. That's the thin PCOS with high LH, high androgens, more acne, more alopecia, and that spectrum. But the other spectrum is the hyperinsulinemic group. And in the reproductive age group, what we're concerned about, of course, is infertility. But then it doesn't stop there. The PCOS individual in the perimenopausal age group can give us gynecologist trouble also. And that is cardiovascular disease, diabetes mellitus, metabolic syndrome. And because of unopposed estrogen action all through her menstrual life, 3-fold increase in the incidence of endometrial cancer, breast cancer risk also increases. So these are the worrisome things that this individual can get into. This is the reason why we should be diagnosing PCOS for sure at adolescence and start initiating our management. Next, please. Why is it needed? It's needed to adequately treat the presenting symptoms and also to prevent long-term complications that we've talked about, because it's a reproductive metabolic syndrome, which is the right name for it, with lifelong implications. It's our obligation when they turn up to us at adolescence to try to stop these long-term implications. Next. So what do we view as the conventional diagnosis of PCOS? This is, of course, the decades-old Rotterdam criteria, which is at least 2 of the 3 criteria should be present, is what it says. Oligo or anovulation, hyperandrogenism, which can be either clinical or biochemical, and a polycystic ovary, which was originally described as over 12 follicles, 2 to 9 mm, ovarian volume over 10 cubic centimeters during the period of ovarian quiescence. Okay, please don't pay attention when your radiologist reports it at any old time, calling one ovary polycystic ovary, which happens all the time, that it's not even annoying any longer. It's very distressing because these children are labeled on the basis of one ovary having multiple follicles, as there is no such a thing as right ovary polycystic, left ovary normal. That doesn't happen. Okay. So the definition during the period of ovarian quiescence, which is right after a period. Next. So how do we differentiate normal adolescence from PCOS? Because diagnostic features in an adult PCOS can be very similar to normal pubertal physiological events. Okay, what happens in a young woman, even if she's normal, is different from this. And how we can look at it: hyperandrogenism, acne, is common in adolescents. Hirsutism is not that common because it takes longer time to develop in PCOS or otherwise. Irregular cycles, common in adolescents. Anovulation, common in adolescents. Right after menarche, even in a normal adolescent, 85% of the cycles in the first year are anovulatory. Up to the 3rd year, it remains, the majority of cycles can be anovulatory. And ultrasound findings are very confusing, different shaped follicles, different size follicles, and it may be very difficult to do in an obese teenager as well. So how do you differentiate this from, what happens in PCOS in adolescents? The first difference is that all 3 of Rotterdam criteria should be present. It's not 2 out of the 3 anymore. It's all 3 of the Rotterdam criteria should be present. Its change in the criteria is, and the age criteria changes as well. The oligomenorrhea, amenorrhea should be there at least 2 years after menarche, not when we talked about right in the first year or second year. Anovulation or oligomenorrhea is not an indication of PCOS. It can be either primary amenorrhea up until the age of 16 years or severe oligomenorrhea or anovulation after 2 years of menarche. And hyperandrogenism, biochemical evidence rather than clinical signs alone. Ultrasound, increased ovarian size, and stroma. Both should be there. Okay. Next. So, and how do we see these adolescent PCOS? Those are the diagnostic criteria. How do they come to us? They come either they're brought to us by their parents, cutaneous signs of hyperandrogenism, menstrual disturbances. And this is the distressing part of it. Polycystic ovary is diagnosed by ultrasound. Otherwise, the child is absolutely normal. It has some tummy ache, and a surgeon sends her to a radiologist, and the radiologist report as right ovary polycystic. Okay, the surgeon goes in to take the appendix out and burns the right ovary as well. It's a distressing situation that we're seeing all the time. It is not because of the multiple cysts are there in the ovary, because of local inflammation and not because of PCOS. So PCOS finding by ultrasound alone, and especially when it's limited to one ovary, does not make that individual a PCOS, which all of us will have to completely recommend to all our other specialists as well, because sometimes these ovaries are burnt totally unnecessarily. And obesity is a relevant thing. It has to be abdominal. Every obese child is not PCOS. Okay, every PCOS is not obese either. It has to be if you do have a PCOS child as obese, it's got to be higher waist-hip ratio. And evidence of insulin resistance also you'll have to find either by investigations or acanthosis, hidradenitis, or skin tags, or one or other. And other investigations may also be required. So clinical findings, you have to have all 3, and all 3 are slightly modified. Next. So this is something that we have to emphasize again and again, because a lot of times every obese child gets called in as a PCOS, but not every adolescent PCOS is obese, and the other way also it's not true. Stringent criteria for diagnosing for all the 3 criteria should be applied by all of us. Next. So, but PCOS can be the most common obesity-related endocrine syndrome in a female, but the obesity has to be a central and android type of obesity. Waist circumference over 88 centimeters in adolescents is not normal. Body fat content should be excessive for BMI. Reported incidence of obesity in this PCOS something like 50 to 75%. So obesity alone should not make us diagnose PCOS. Next. Physiologic adolescent anovulation also is common. Then what should you call as abnormal? Primary amenorrhea by age 15, primary amenorrhea until 3 years after breast development. So a child gets a breast development, still remains amenorrheic for 3 years or longer, that is abnormal. Secondary amenorrhea should last longer than 90 days. Next. Abnormal in the menstrual cycle. Year 1, the cycle length should be over 90 days to be called abnormal, or less than 4 cycles per year. Year 2, after menarche, more than 60 days and less than 6 periods in a year. Year 3, cycle length more than 45 days and less than 8 periods in a year. Or excessive anovulatory bleed can also be there, prolonged bleeding, heavy bleeding, and soaking a lot of pads. Next. Next, please. Premature pubarchy, that is sexual hair in the pubic area appearing very early, can be an uncommon manifestation, early manifestation of PCOS. So if a child is brought to you around 8 or less, pubic hair only happening, you have to look for the possibility of PCOS later in life. Next. So hirsutism, if it's mild, it can be idiopathic. Only moderate to severe hirsutism is relevant. That usually takes time to develop. Acne, moderate to severe inflammatory acne and poorly responsive to conventional treatment. Seborrhea, hidradenitis, which also indicate hyperandrogenization. But however, frank virilization is not a finding in PCOS. In other words, things like temporal hair recession, increased muscle bulk, voice deepening does not occur. Next. What is abnormal is inflammatory acne, moderate to severe, over 10 lesions in the face, persistent and responding poorly to topical treatment. Next. And hirsutism has to be differentiated from hypertrichosis and excessive, which is only excessive vellus growth in non-sexual pattern in forearms and legs. So that can be other things like familial, hereditary, or ethnic causes. Next. Unwanted face and body hair or alopecia having negative social, psychosocial impact, and terminal hairs should be longer than 5 mm in length, variable shape and pigmentation. Next. So this is something that we have to teach all our students and youngsters to do, modified Freeman-Galway, 9 body parts scoring 0 to 4 each, and the score should be over 6 to call it really a hirsutism. Next. So excessive coarse thick hair in sexual area, and the score goes like this. Above 8 may be abnormal, but severe hirsutism is above 24 really. Next. PCO morphology, ultrasound should not be used for diagnosis of PCOS in those with the gynecological age of less than 8 years due to a high incidence of multifollicular ovaries in this life stage. It's seen in 40% at 2 years after menarche, and 35% 3 years, 33% is 4 years. So you have to wait for a while before we start using PCOS morphology as part of this triad. Next. So this has changed over a period of time. This has been, the whole concept about how to diagnose this has changed as well. But the number of follicles per ovary has changed, and the ultrasound machines have become better, and we have become better in doing vaginal scans, and not in an adolescent, but otherwise. So the number keeps on increasing as the sensitivity of ultrasound machines is increasing. AMH is another possibility. 5 nanograms per ml is more sensitive and specific than follicle numbers. Next. So proposed diagnostic criteria for PCOS in adolescents is hyperandrogenism, which is biochemically confirmed, menstrual irregularities present at least 2 years post-menarche, and polycystic ovaries, which has to have both increased size of the ovaries and increased number of follicles. Next. Next. Biochemical testing, total testosterone and 17-hydroxyprogesterone are the most commonly done. even though a lot of labs are adding on a lot of things, they're really not necessary for you to make a diagnosis of PCOS. Free testosterone, free androgen index is 10 times more expensive and really has not much of a role in diagnosing. And androstenedione has absolutely no role in diagnosing PCOS. Total testosterone is relatively easy to perform, as majority of labs do it and is commonly available. And 45 to 60 nanograms per ml is considered upper limits of normal. Over 150 require evaluation for more serious causes. Next. Free testosterone, as we said, it's more sensitive, but its standardization is difficult. Not all labs do it, and it's very expensive as well. Next. Protein estimations of other androgens is actually not needed when you're suspecting PCOS. DHEAS helps when you're thinking about very severe hyperandrogenism, something like adrenocortical carcinoma. High levels are there, and cortisol is only when you're thinking of Cushing's based on history, clinical examination, centripetal obesity, hypertension, striae, proximal muscle weakness, then you look for cortisol. Next. Next. So insulin, no standard validated assay for insulin. Insulin levels don't have to be done either. Next one. So non-classic congenital hyperplasia is the most likely disorder. Give me another 5 or 10 minutes. I'll try to finish it. Next one. Yeah, we talked about it. This is where you do the 17-hydroxy. Glucose tolerance is essential. Next. 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 AMHS. So at risk of PCOS can be a diagnosis as well. In other words, if you cannot be sure about the diagnosis, you can call an individual as at risk of PCOS, monitor her longitudinally rather than label her as PCOS. Next. Family evaluation counseling is required. It's a necessity. Siblings need to be evaluated. Parents also sometimes need to be evaluated. Next. Managing is managing of the symptoms actually. It can't cure the disease. Abnormal uterine bleeding, cutaneous hyperandrogenization, obesity and insulin resistance. And pharmacological therapy only if it's necessary. Next. Management concern is actually a desire for immediate improvement of presenting symptoms, often the focus of patients and families. They bring this child to you wanting you to do something magical to make it better. But actually your concern is more menstrual dysfunction, hyperandrogenism, and the later metabolic risks. So there has got to be an equation between you and the parents. Next. So the first line treatment is oral contraceptive tablets. And next. Why OCPs, estrogen and progesterone? Estrogen suppresses the HPO axis and makes the abnormality less of androgen production and increased binding globulins from the liver. And progesterone inhibits endometrial proliferation, decreases endometrial hyperplasia, aids in shedding the endometrium. So what do we choose and what kind of COCs do we choose? Estrogen has to be 30 to 35 microgram, not the usual 20 micrograms that we're choosing, because less effect to control AB with 20, inadequate to promote normal bone mass as well. So prefer the 30 microgram or 35 microgram. And progesterone, less androgenic progesterone. This is where you have to be careful because norethisterone groups are all androgenic. That's where the majority of BCPs are. And if you give it to them, it can make the hyperandrogenic symptoms more. So you'll have to choose a less androgenic progesterone, which is either drospirenone or desogestrel. Next. Adverse effects, a lot of them we know of, but the benefits in this particular situation far outweigh the potential risks, and that's been proven. Next. Yeah, the benefits have been proven. How long do you give it then? The optimal duration of treatment has yet not been determined, but however, you can advise them to continue treatment until the patient is gynecologically mature or has lost a substantial amount of excessive weight. I think this is the crux of it. If you encourage them to change their lifestyle, a lot of them do become better along with the OCPs. And once that happens, you can be much more generous about withdrawing the BCPs. Next. Is there an alternatives? Progesterone can be given to regulate the cycles, but progesterone's only menstrual regularity is corrected. The rest of the syndrome is not corrected. Next, does not reduce androgen levels, no reduction in hirsutism if you use progesterone. So you also have depression, bloating, etc., etc. So treat hyperandrogenism symptomatically, the skin treatment. Next one. Very severe cases may need anti-androgen treatment as well. So choosing the right progesterone in the BCP is the most important thing, which is drospirenone or cyproterone acetate. Next. Counseling is vital. At least 6 months of minimal treatment is required to see some results, which you have to counsel the patients. Next. Anti-androgen therapy only if it's required. Next. If it's very severe and required. It's challenging because it has its side effects also. So you've got to be very careful not to overuse anti-androgens. Next. Next. Does not screening for metabolic abnormalities is very important. All of those things can happen. Okay, next. Normal glucose tolerance. This is one of the most important things because this is what the prevention of the later problems comes up with reducing the glucose intolerance in them. Next. Next. That is what they require this for. Next. Metformin is one thing that we have used for as an adjunct to lifestyle modification and symptom-based treatment. Dysglycemia and insulin resistance should be considered as an indication for metformin. Next. So it has all these favorable effects which we know of on the metabolism. Next. Myo-inositol has been a good alternative as well. Component of vitamin B complex, so less threatening to the patient and less threatening to the individual. So insulin sensitizer, improves insulin signaling and reduces serum insulin, decreases serum testosterone and restores normal ovulatory function. Next. Myo-inositol is a component. Okay, this side, that's a different talk by itself on myo-inositol. I'm not going to get in there, but this helps us also. Safe and effective to prevent correct metabolic and disorders in the adolescent PCOS. Many people are little hesitant about taking metformin, but the combination of MI and OCPs, most of the effects can be the same. And simultaneous treatment with MI and OCPs and the lifestyle modification can be considered as a highly effective approach in adolescent PCOS. Show favorable effect in all of those things. Next. But the only thing is the maintenance when symptoms are controlled. The difference is that metformin is less expensive, time tested, long-term use, more GI side effects and less compliance. Whereas myo-inositol is definitely much more expensive. It's a relatively newer drug, but more user-friendly. I think I'll stop with this. I think I've taken too long a period of time already. I'll stop with this. Thank you. Lifestyle modification. I'm sorry if I took too long a time.
No, it's okay. Okay, madam. Pushpa, madam, can you please unmute yourself? Madam, please unmute, ma'am. Pushpa, ma'am.
Yeah. Hello. Hello, am I audible?
Yes.
Yes, ma'am.
Thank you, Dr. Mridubhashini. That was a very nice lecture. And especially I like your emphasizing that DHEAS and insulin need not be measured because a lot of and free testosterone. I think these are the take-home points from your thing. Yeah, it is very expensive, free testosterone, and as you said, it's not very standardized also. Like you do it in different labs, you get different values. DHEAS maybe raised a little bit in some PCOS patients, but it really doesn't
Make a difference.
Add much meaning to us, especially in adolescent. And when you suspect something, of course, imaging, DHEAS, and everything can be done for it, which is also a good take point.
I was told by the endocrinologist, if you have a normal sugars and the normal lipid profile, sometimes a fasting insulin can be on the higher side in order to predict the metabolic syndrome in the PCO girls. Using fasting insulin.
I think it's again a cumbersome test and it's an expensive test, and hyperinsulinemia is something that you and I diagnose clinically majority of times. You know, the android obesity, when they walk in and they've got a waist hip ratio which is abnormal and the skin tags or whatever else that they have, they definitely have it. Metabolic syndrome is not just insulin. Metabolic syndrome, I'd rather measure the rest of the things also. in a metabolic syndrome. Okay. And then there are 5 or 6 components. It's better that you look at it because that's more relevant to this girl's future than a serum insulin. Neither are you expected to monitor serum insulin levels fasting or monitor them sequentially either. Worldwide, I think the recommendation is, you can't just check the sugars. It's not going to be abnormal. Clinically, you know that they are hyperinsulinemic. Treat them as hyperinsulinemic.
Especially in case of a lean PCOS, what is your inference on a HOMA exam? Evaluation, ma'am, because they don't have an android obesity, but still they have a lean PCOS,
They won't.
have a high insulin resistance. That's very. Can we have that?
It's possible. It's possible. In which case, I may not choose metformin, but I may choose something like myoinostar. But there, it is the LH rise and it's the androgen rise, and what I have to look at is the androgens more than insulin. It's the typical FSH-LH ratio changing and acne, full of this thing. So the what you worry about is the androgen floating around in their stream rather than the insulin.
Madam, what is your take on using insulin sensitizers during pregnancy when we are treating the PCOS women with metformin and continuing it during the pregnancy? Because these women have a tendency to give birth to PCOS child because of the hyperandrogenism. So do you think continuing metformin all through the pregnancy or at least in the first trimester would reduce the environment and improve the outcome for the child?
Mala, very interesting question that you're asking. It is not just the hyperinsulinemia, it's the inflammatory status that the hyperinsulinemia produces that gives rise to a lot of problems in pregnancy. Okay, there are papers, cervical incompetence, the cervical incompetence that happens with no known cause. You've done a cervical length, it's absolutely okay at 13 weeks. And you've asked them to come back at 20 weeks, and she turns up to you at 16 weeks, totally open cervix.
It's hyperandrogenic.
It's a hyperandrogenism. That is always
a lot of them have PCOS.
Cervical incompetency.
One or another. So that highly inflammatory status in pregnancy can give rise to any kind of problem. So I do believe in metformin. It's such a, that you're not going to do any harm, neither to the mother nor to the baby. Okay. And I'd rather err on the side of a highly androgenic mother becoming pregnant, putting them on, I can't say that there's absolute literature proof for that, but I think it makes sense because you do see, especially when you go for an IVF and you created this pregnancy after so much of struggle, the hyperandrogenic ones are difficult with, even with ovarian stimulation. Those are the ones who will not respond to you up until a stage and then blow up in your face. Okay. That is the typical thing that happens with the hyperandrogenic, and they follow that trend through the pregnancy, giving you surprises because of the hyperandrogenic state.
But most of the endocrinologists prefer to start insulin.
Why do you want an endocrinologist to treat your PCOS?
No, what I'm saying, ma'am, they don't believe in metformin. They don't believe in metformin. They
read 2 studies on metformin, which are, if you really read it carefully, Kundavi, a lot of things they say that if you use clomiphene alone, your ovulation rate is same. If you use metformin, it's the same. So therefore, metformin is useless. That kind of studies, plenty are there. Like you're looking at an endpoint, which really doesn't tell you what it does for the inflammatory status. Okay, so it's not looking all of the inflammatory things that can happen in pregnancy. So I don't think, those kind of studies, if you are focusing on that, it's there with small numbers. I'm sure that's there. But I would say be careful with PCOS pregnancies more than anybody else, especially the hyperandrogenic ones. You struggle, hyperandrogenic ones, that sometimes, they're the 25, 30 follicles sitting in there. You use very low gonadotropins, they will not stimulate for you, and you keep creeping up, and suddenly one day they blow up. Okay. That's the typical.
I never stopped the metformin till her delivery. She'll be continuing, ma'am. And I've seen a very good improvement in the fetal and the maternal outcome.
I think you're right.
Especially, yeah.
We
don't produce this data, but I have a very practical experience.
No, I think people who are doing a lot of obstetrics know that, and it's not just you. Majority of people know, and I've heard obstetricians 30, 40 years ago, people like Stuart Campbell and those kind of people, before all this happened with metformin or PCOS and all that kind of a thing, he would say if, any baby that acts like a hyperinsulinemic baby, puts on a lot of weight inside and shoulder lengths are better. Those are the sudden intrauterine deaths that they're getting. A lot of them were because of metabolic problems in the mother, the carrying the mother. So I think a lot of known and unknown things do happen with hyperinflammatory status, and that androgenic more than hyperinsulinemic, they are definitely inflammatory in an inflammatory status. So personally, yes, I'm more generous with metformin.
Thank you so much.
Agree
ma'am.
with you, ma'am.
I have a question, Dr. Mridubhashini. You feel that in lean PCOS, you would rather avoid metformin? Is that your...
No, not really. They may have a component of hyperinsulinemia as well. They usually do. It's sort of a spectrum between this and this. It's never isolated this or that. Somewhere a mixture of both. It's what's more prominent is giving rise to the clinical symptoms.
So you rather lean towards myoinositol rather than metformin in lean PCOS?
It's easier to convince them. Also, it's easier for them to
Tolerability
take.
is very good, ma'am. Tolerate well.
Only
Dr.
thing is, it's a
Usha,
bit more
would you like
expensive.
to tell something? Dr.
There's
Usha?
people give combination of myoinositol and the metformin too, because each acts in a different way.
Madam, but metformin does seem to reduce the birth rate of the baby. That's what you have understood. Beyond 28 weeks, there's a slight restriction of growth.
There are single studies with small numbers which
No,
claim.
we have seen the people whom we expect around a 3 kg baby, it's born with 2.6, 2.7.
But they never go for a macrosomia, ma'am. They
They
never go for a
never go for
macrosomia.
macrosomia.
Or a
I
sudden
would more worry
IUD.
about the
Sudden
3 kg
IUD
baby.
is very unusual with metformin treated. I've seen many such patients, ma'am. Even obese PCOS, they fare very well when you continue metformin.
I think the risk for the preeclampsia and everything also, it's very,
It's
very
down, yeah. Lower.
You didn't
Yeah.
face any after putting them into metformin. And adolescents do very well with myoinositol.
Easier to get them to take it because the GI things are.
The most important thing is like how long to continue these treatment for these girls, because after
Mala,
a of time, the
that-
patient find it very difficult to continue. The mother's anxiety is building up. So do you have any kind of criteria as to I will give it only for 6 months or maybe a year or something like that?
The way I counsel it, it's
You have to
usually
educate them for the
required
lifestyle.
for a longer period of time. I dangle this lifetime thing in front of them. You do that well, and I can take you off the medications.
Exactly, madam. So we ask them to reduce the weight. That is a challenging thing for them, in fact.
Yeah, there's more motivation if you say you'll stop the medications.
Yeah,
For the
but
parents.
I heard somewhere that like if you get like 6 cycles in the year, it is more than sufficient. You don't have to worry in between like.
It is not the cycles that you're worried about.
Hyperestrogen.
I said
Hyperestrogen.
other things.
Endometrial hyperplasia and the
So for
other
6
things is a
months,
one-to-one.
For 6 months of OCPs and then allow her to, with lifestyle modification.
What we have to remember is we're not treating the periods.
Yeah.
We're just not regularizing the periods. We're treating the syndrome.
Yeah. Okay, that was excellent, ma'am. Yeah, thank you so much, Dr. Mridubhashini, madam, and Pushpa.
To have been with you.
Very, very wonderful, and such a lucid, explanation of the entire pathogenesis and the exact nature why PCOS is multifaceted has been very clearly and beautifully explained by you, ma'am. And thanks for the lovely interaction by all our faculties. We move on to the next speaker. We have Dr. Jairani Kamaraj, madam, and may I request Dr. Usharani, madam, to introduce Dr. Jairani Kamaraj, madam. Usharani, madam is the professor of Sri Ramachandra Medical College, University, and is a great teacher. And I was very, very fortunate to be her student. Not only her teaching, but the way she handles her patients, her compassion to patients, and the patients are phenomenal. And we have to learn quite a lot from her. A very calm and composed person. And may I request Usharani, madam, to introduce our next speaker, Dr. Jairani Kamaraj, madam.
Thank you, Mala, for the kind words. In fact, Dr. Jairani Kamraj would be the best person to be doing this session on fertility in polycystic ovary. She is our dynamic president and very active in all her work right now over the last 1 year. You're doing a great job, ma'am.
Thank you, ma'am. Thank you.
Yeah, and as your she's an infertility specialist and she's been in the field for so many years. And let's go ahead and listen to her as to how to handle and how to crack these eggs in this PCOS.
Thank you, ma'am. Thank you for the introduction. And I hope after very, very elaborate, depthful, and a very interesting session by Madam Mridubhashini Madam, now we are into a very stressful or a tricky way of how we are going to treat the fertility issues. Can you see my presentation?
Yeah,
Madam?
yeah. Yes,
Yeah.
madam. Yes, madam.
Is it okay? Yeah.
Yes, it's good.
So now comes a very important and very challenging work. That's the fertility challenges, what we come across in this PCOS women, because we know the basic pathology is very dreadful, as pointed out by Madam, the insulin resistance, the abnormality in the hormonal imbalance, the various endocrine changes. All these things are really challenging for a fertility specialist like us, whom we treat this patient to get her a pregnancy, which is a real challenge we come across, because each PCOS patient is different. You can't standardize any treatment for anyone because everybody will behave very differently and we don't know exactly how each one will respond. So it is a real challenge. As Madam rightly pointed out, 30% of the infertility population who enters into the infertility clinic is a PCOS women. And also when you look into the causes for the female infertility, 40% is the ovulatory disorder. And out of the 40 disorder, 85% are the PCOS. So much is the volume of the PCOS women attending the fertility clinic because they are reproductive age group. This is the commonest endocrinological problem. And for a women with an infertility, this is one of the important cause, which if treated will give a very good pregnancy. And if it is not treated properly, it's going to be a lifelong problem. Because I hope that all the fertility senior specialists here will agree with me. This is the only condition when you have a greatest problem of how you're going to produce her eggs. Because she has a plenty of oocytes, she has plenty of ovarian reserve, but still her response is totally unpredictable. So you may think that she may not respond, she will suddenly flare up. You may think that she will respond well and start her with a low dose, she never respond. And sometimes when you really get her a good follicle, you think that she may have a 15 to 20 oocytes, but nothing will give you a good quality embryo. And all the more she has a lot of problem, as rightly pointed out by Madam, the pregnancy related complications are very bad in her. The first 4 months where the embryo grows into a good baby, which is a real challenge because they have a high risk of miscarriage, anomalies, everything. And in the mid trimester, they have a high risk of all the preterm labor. And in the last trimester, they have all the problem of your diabetes, PIH, eclampsia, everything comes into this women. So she not only faces a problem of fertility, but also she has a high risk of all the pregnancy complications, which even any gynecologist or any obstetrician will agree with me that she is a real challenge for all the sectors of the gynec practice. So PCOS, from the infertility specialist point of view, we have a poor oocyte quality, poor embryo formation, endometrial response is less, and also the ART success, though we have very many follicle growing, but still the quality is not that great when you really look into it. So definitely the fertility treatment for a PCOS women is a real challenge because we have so much oocytes, but the ultimate good quality oocyte is a real challenge because you cannot predict how every woman respond. You don't have a proper way of how to approach. So definitely a treatment of fertility in a PCOS women needs a lot of proper assessment, counseling, drug therapy, and also very many treatment in her lifestyle interventions. If we put forth simply, the 50% is the lifestyle changes and 50% is your technology and your knowledge of treating these women. So that is a very important step because when you're given a PCOS women to treat, you have to start not with the medications, but with the first step of her lifestyle modifications or the interventions, which forms a very important basic, which without which all your drugs and medicines and your treatment, your ART or IVF is not going to give you a great success, because the success of any fertility treatment does not end with a pregnancy alone. It ends with a healthy baby. So you have to start treating the challenge right from the first step, that is the lifestyle interventions. I think about which Dr. Ritu will be talking in plenty, but still I would like to emphasize that from the point of view of a patient's approach, the first step of treatment for an infertility specialist is the lifestyle interventions and a proper counseling of a lifestyle modification, which gives us a good base to work on for the drugs as well as the treatment procedures. So the lifestyle intervention is very important, and with that basis only we can put her on a pharmacological therapy, which includes the oral ovulagens and also some insulin sensitizers and also injectables of gonadotrophins. And when they fail, then the second line is the surgical as well as the gonadotrophin. And at the last or the third line of management will be the proper IVF or the ICSI. So that is the flow of management you do for an infertile woman with PCOS, starting with the lifestyle changes and then the ovulation induction and insulin sensitizing drugs and the surgery. And then the last way is the IVF. So when a patient asks you, Madam, can I conceive with PCOS? Yes, she can conceive, but first tell her that it's possible only with a lifestyle modification, which is the first line of treatment, which includes the weight reduction. That will help her to correct the hormonal imbalance, that will make the drugs to act in a better way and give her a healthy baby. So diet, exercise, her behavioral therapy, then comes the medical treatment and other things. So when you look into the lifestyle, the diet control, exercise, behavioral changes, and of course, nowadays increasing smoking and drinking habits, all these things has to be changed to correct her way of her lifestyle, which is very important. So exercise and food, I think everything will be in detail, everybody knows, but we should have a holistic approach. What type of exercise that you can advise her? The two important steps that you should give her is that, especially obese PCOS women, a proper aerobic exercise and weight training. It's not only the BMI that matters, her waist-hip ratio, which is a very important way to correct her insulin resistance, especially the truncal obesity, which is a very important step that you should keep in mind and treat her with that in mind of correcting that insulin resistance with a proper care of her truncal obesity correction. Even with a BMI normal, she can still have a high insulin resistance, especially the truncal obesity, which should be the idea or the basic of her correcting her and advising her the type of exercise. So ask her to be active, always more energetic. That will help her to reduce the excess obesity that she has, which will help her to get into an optimistic level. So when you ask her about, when the patient asks you how much weight they should lose, we should give them a SMART program. That is, it should be a specific, it should be a measurable, and also it should be an achievable and relevant and also time bound. That's very important. That should be the focus for us, because if you ask them to reduce the weight and come for the treatment, sometimes she won't turn up or she will go to the next specialist. So that will be the ultimate end. So we have to give them a realistic goal to achieve, which should be around 5 to 10% of the current weight. And that should be possible within the 3 to 6 months, which will definitely improve her hormonal status as well as improve her menstrual irregularity and also improve her ovulation. So ideally, advise her 500 calories per day reduction, which will help her to reduce nearly around half kg per week. So a monthly 2 to 3 kg weight reduction. That will help her to reduce the optimum 10% within 3 to 6 months. So you should give her a calorie of 1200 calories with an exercise around 500 to 600 calories, so that her set her a realistic goal to achieve, which will help us to work with that lifestyle reduction. And if you look into the data, definitely a weight reduction up to 4 kg can give her a pregnancy at the end of 18 months up to 53, that is 61%. And also the spontaneous pregnancy rate is also improved without any intervention. And even the ART pregnancy rate is getting improved with this weight reduction. And all the more there is a reduction in the miscarriage rate. So definitely weight loss helps her to get a spontaneous pregnancies also. So that is a very important step that you should keep in mind. Pardon? So in this,
Chitrakala, please unmute. Mute all the delegates, please.
so next is the, so this is the lifestyle changes, which is very important. And next comes into our ovulation induction. And in this ovulation induction, I hope all the specialists listening to me will agree with me. Ovulation induction in PCOS is a big challenge. It could be an ordinary ovulation induction or a super ovulation, or even for a IUI or for your IVF. It becomes a real challenge. How much drugs, whether she will respond, whether you are understimulating her, or she gets into an OHSS, or how we are going to get into her a cycle without a cancellation. All these things is a real challenge in a woman with PCOS. There is no standard way to say how much she will require and how long she needs to get into a proper or optimal stimulation, which is a real experience and expertise, as well as it needs a lot of inputs. So the drugs of choice, especially for the oral ovulogens to start with, will be the clomiphene citrate, which is like anything like a holy drug for this PCOS women. And we have in the armamentarium the letrozole, and also to add on to it, we have the insulin sensitizer, the metformin. So you have to have all these drugs in mind before we plan for the therapy. Always make sure that she get a menses, rule out a pregnancy, because many a times she comes with an amenorrhea. You may miss a pregnancy, or she may have a scanty flow thinking that it's a she has menstruation, but she may have even a pregnancy. Make sure that she has a proper withdrawal without pregnancy before you start any ovulation induction. So the first line of treatment, it could be either a letrozole or it could be the clomiphene citrate, because each one is good in its own way. And anyone who is using clomiphene citrate, if you still ask, still they believe that CC or the clomiphene citrate is the first line of treatment for them. And of course, the letrozole, which is the first line, which gives you a monofollicular development test. Some people still believe that CC can be added. So any drug at your convenience can be given, but always keep in mind, when you start with clomiphene, you have to think of the endometrial poor receptivity, because the endometrial response is going to be very thin when you are using the clomiphene, whereas that is not there with the letrozole. And also there is a monofollicular development more with letrozole, and there is a reduction in the OHSS and multiple pregnancy with the letrozole when compared with CC. So usual dosage, we start with 50 milligram, and it can even go up to 150 to 200 milligram. And usually we give a HCG trigger, and then of course give her a progesterone or the luteal phase support. The same way for the letrozole, start with 2.5 to 5 milligram right from the day 2, and then of course monitor and give the trigger. So this is the usual drug. So how the treatment with CC, the ovulation rate will be up to 70 to 86%. And the pregnancy rate will be around 35 to 45%. And there is a miscarriage rate up to 13 to 25%. Then this has been studies up to 5,000, 6,000 cases has been studied. And if you look into the other drugs, especially tamoxifen, can they be used? Of course, they are the same way, both the treatment and the outcome, everything is going to be the same with the tamoxifen also. In addition, clomiphene can be given along with dexamethasone, especially in a PCOS women. They have a better response when you treat them along with the dexamethasone. The ovulation induction or the ovulation is better. So if you look into the ovulation induction with the clomiphene and their chances to ovulate and conceive, if you see around 3 cycles, the initial phase of the stimulation, if they respond well, their pregnancy rate is very good. And after 6 cycles, if they fail to respond, then this clomiphene is not going to act for any more years. The same way, there are a lot of studies comparing letrozole and clomiphene. If you look into the ovulation rate, it is almost the same. There are 4 or 5 studies they have conducted and state that almost both are the same. So you can choose anything of your choice to use for the ovulation rate, because it's almost the same with both the drugs. And if you look at the pregnancy rate, that also is almost similar with both the studies they've compared. So both drugs can be given according to your convenience, your expertise. But sometimes you are left with a choice, which drug can I use? To put it very simply, there have been a lot of studies which states that in a woman with a PCOS where she has a high estradiol level, the basal estradiol level when it is high, you can give her with letrozole. You can start her with letrozole because she will respond well with letrozole. Whereas a woman with low estradiol, basal estradiol, they will respond well with clomiphene. So that is a one simple point you can note down when you are planning for a stimulation in a PCOS women. Depending on their estradiol level, you can choose which oral ovulogents you can put her on so that you will have a better response and better ovulation. So next line of treatment will be your gonadotropin. So women who are resistant to oral ovulogents or who have an undesirable anti-estrogenic side effects on the endometrium or a thin endometrium, you can put them on the gonadotropins. They are used as the second line agents for ovulation. They have a very good induction. They are mainly indicated for women who fail to ovulate with the oral ovulagents, or they don't get a pregnancy after 6 cycles of proper ovulation. So these are the group of people who you advise a gonadotropin. The only thing you need to have a proper monitoring, and you should always keep in mind about the OHSs, and also you should have a option of converting anytime for an IVF if you are inadvertently giving them with a proper stimulation. The cost and other things also you should keep in mind when you're planning for the treatment. So this is highly indicated for women who fail to respond in the ovulation after 3 or 4 cycles of clomiphene, successive cycles, and who fail to conceive even after ovulation happening within 3 to 6 cycles. After 6 cycles of ovulation happening, still if she fails to conceive, then we opt for a gonadotropin therapy. So gonadotropin therapy, it is which drug can be used for the PCOS, especially I'm concentrating more on the non-IVF cycles. I'm not going into IVF at all. It is all for the simple ovulation induction in a PCOS women. You can use any one of the drug choice. It could be a HMG, it could be a highly purified HMG, or even it could be urinary FSH or highly purified FSH and a recombinant, which can be given along with clomiphene and also can be used along with letrozole. And this can be used with IUI or later on even an IVF. So there come one big question, why there is an abnormal response, especially in a control ovarian stimulation in a PCOS women. This becomes a big challenge because many times we don't know exactly how much is the threshold of the gonadotropin dosage or how much we should give for it. It is very difficult to find the gonadotropin threshold for any PCOS women, which is highly variable. And also, even if she has a very high recruitable pool of follicles, though she has it very much increased, but still we don't know exactly how much will respond and how many oocytes will be flaring up. So that is also very importantly a challenge. And third, the stromal hyperplasia, which continues to be larger than the normal amounts of androgen to the follicular microenvironment. That also has an impact on the response to the stimulation. And the granulosa cell aromatase activity usually is very much decreased in this PCOS women. And that is also very importantly needs a lot of exogenous FSH. So these are all very important challenges we come across in a PCOS women when you plan for a controlled ovarian stimulation. And sometimes their follicular response will be initially very slow. Suddenly they will respond. So you need to have a proper careful monitoring. You can't just leave them that they are very slow in response and suddenly they come with a hyperstimulation. So all these things are very, very important. So how you're going to plan her gonadotropin cycles, which is very important. What will be the starting dose? How much you're going to give? This depends upon the 3 important variables like the age, their antral follicular count, their AMH, and also their history of previous response. So these are the very important things that you should plan when you're planning for the dosage for this gonadotropin, how much you should use. So we have age, AMH, FSH as a criteria. And from this, we can apply the formula of the ovarian response predictive index, which uses this AMH in nanogram per ml, which is multiplied by the AFC count, which is divided by the age of the women in years. So this is the simple formula you can use when you're using how much dosage you have to calculate for this women, depending on this ovarian response predictive index. If the ovarian response index is less than 0.2, then you expect around 3 follicles. Then the ideal protocol will be a GnRH long protocol, or antagonist protocol, or a short protocol. If the value is between 0.2 to 0.5, we expect around 5 oocytes. Then you can use either an antagonist protocol or you can use a short protocol. If you have around 0.5 to 0.9, we expect around 6 to 14. We can use the antagonist or a long gonadotropin and long agonist protocol. Or if it is more than 15, it is only the antagonist protocol. So this is the very simple thing that you can plan to get how many follicles you will get from her. So what are the protocols that you use in this women? Usually the conventional dose, you all know, it's the simple standard dose. You start and continue, and when the follicle reaches around 16 to 17 mm, you triggered. And that is another way is you have to have a high step-up protocol, which usually around 150 IU continue, and after 7 or 8 days of stimulation, if there is no response, increase to 225 IU. These are all very dangerous for the PCOS women. But still, as a completion, I want to tell you, because such things should be very careful when you're dealing with the PCOS women. This conventional dose or a high dose should be very careful for the PCOS women for a normal non-IVF cycles. It can be given for an IVF cycle, but not for a non-IVF cycle. How you program her for a non-IVF or an IUI cycle, it is usually a step-up protocol, which can be a low-dose protocol or a chronic low-dose protocol. So usually the low-dose protocol, we start with 37.5, give her for 7 days, then see her response. If there is a poor response, increase 50 to 100%, and then keep on increasing every 7 days. This is a low dose protocol. Chronic protocol is you start with 37.5, continue for 14 days, and then monitor her. And then if there is no good response, there you increase. This is what we usually advise for the PCOS, especially with a very high AFC, very high androgen. These are the type of protocol that we always give is a chronic low dose protocol, where you can have a good, proper monofollicular response. Step down protocol, there we give a higher dose, and then after 4 or 5 days, you decrease the dosage depending on the response. And then if there is a still more increase, decreases after 5-6 days. This is the step down protocol. They have a loading FSH dose, but there is always a problem with this protocol of a step down protocol. And another protocol is a sequential protocol, where they give to start with the 37 and then increase, which is an ideal one, always good for a single follicular development, which is a sequential protocol. So when you look into the outcome of this protocol, the step-up protocol, there is a high incidence of pregnancy. There's a good pregnancy rate. But if you look into the step-down protocol, there is a high indication, higher OHSS and lesser pregnancy rate. So for a PCOS women, the step-up protocol is always the ideal protocol to give a good pregnancy. And overall, if you look into the clinical pregnancy, it is always good with a step-up protocol, whereas with the step-down protocol, there is a high risk of OHSS. Which drugs to use? There are a lot of questions, whether to use a recombinant or a highly purified or the FSH, purified FSH. What is the ideal protocol? There have been a lot of studies, retrospective studies of more than 600 cycles they have studied. What they have found out is the ideal conclusion, what they made from these studies is in antagonistic protocol, different the gonadotropin products are equally effective. The choice of one or other should depend on the availability, convenience, use, and the cost. So there is no specifically not much of a advantage of each one with the other one. But one thing what they have noted it with the recombinant FSH, there are more mature oocytes, more embryos, with a low dose of a gonadotropin. That's what they found out in this retrospective study, but they never recommend anything specific which can be given according to the patient's convenience. About the gonadotropin GnRH antagonistic protocol, that is the best protocol we advise for a PCOS women, because there is a definite reduction in the OHSs without reducing the likelihood of the achieving a live birth. So always keep in mind an antagonistic protocol when you plan for a IVF procedure for a PCOS women. And then comes to the metformin. We know metformin plays a very important role in improving the ovulation induction in the women with PCOS through many of its effects, like reducing the insulin levels and altering the effect of the insulin on ovarian androgen synthesis. And also it helps to improve the theca cell proliferation and improves the endometrial growth. It has a direct effect on the oral gluconeogenesis and thus reduces the ovarian androgen production. And it can be given up to 2 grams per day, which will have a definitely adjuvant effect for the ovulation induction, either by itself in women with PCOS and also along with other ovulation induction drugs, which will definitely have a better improvement in the metabolic and the reproductive outcomes of a women with a PCOS. So definitely metformin plays a very high role, and thereby it causes a lot of advantages, reducing the risk. And there have been a lot of studies which have given an advantage that the people with PCOS undergoing ovulation induction with gonadotropin, addition of metformin definitely improves the rates of clinical pregnancy and live births and reduces the cancellation rates. And also in patients with PCOS undergoing ART procedures, metformin co-treatment reduces the OHSs and also increases the pregnancy rate. And also there is an improvement in the reduction in the abortion risk, especially in women with PCOS. And also there is a reduction in the major anomalies in the PCOS women. And also the women's outcome, either in the GDM or a PIH, is better with metformin. So all these things we were discussing with Madam, and it has been proved by various studies. And now the next one is the myoinositol. Nowadays we are talking more about myoinositol. Is it a good drug? What is its experience? Definitely, it has a very good improvement in the insulin sensitivity, decreases the insulin resistance, improve the glucose utilization, and also reduces the free and the total serum testosterone, provides a good quality oocytes, and improves the menstruation and ovulation, and also improves the pregnancy rate. There have been a lot of studies where they've said that inositol and other nutraceutical synergetic actions counteract the insulin resistance in PCOS women and the metabolic syndrome, which is a very important future perspective for the treatment of the myoinositol, which is in a combination of myoinositol and dicarbonyl, has been very much improved insulin sensitizers and has increasing the very good metabolic outcome in the women. So supplementation with this will be a very complement to one another, which will be very helpful of its synergistic effect on the insulin sensitizing effect, and also as a nutritive method also. So it is very importantly can be used along with clomiphene, as well as especially in women with a ovulation who are not improving well with metformin. You can definitely try with myoinositol. There have been a lot of studies which state that after myoinositol treatment, ovulation was improved up to 61%, where they are found to be resistant, they have much more improvement. So definitely myoinositol treatment ameliorates the insulin resistance and improves the body weight and improves the ovarian response and activity in the PCOS patients. So very, very importantly, these are the drugs which can be used. And next comes the surgical question, the PCO drilling. Are we going to drill the patient? What is, why, who, what are the indications? Who will be responding well to this drilling? So that is a very important challenge. So very importantly, this drilling is indicated to reduce the hyperandrogenism and improves the intra-ovarian milieu. For that only the PCOS drilling is advised. It needs a lot of standardization because there is a very poor standardization in the form of indication, modality, how many pricks you have to use, how much current you should use, how much oocytes will be altered, whether you have to go for a cortical puncturing. All these things is a real challenge, and definitely it is only indicated for a women who have a high androgen, and also it is very importantly can be done only for a thin PCOS. So laparoscopic drilling, it is only for the clomiphene resistant women with a body mass index less than 30, with the LH hormone very high and the AMH very much more than 10, they are the one who are highly indicated for the PCOS drilling. Ideally, it should be given 4 or 5, where they are planning, the perforation on the surface of each ovary bilaterally using a monopolar or a laser energy. And there have been a lot of RCTs which have given a very good improvement in the clinical pregnancy, live birth, and miscarriage rate is very much lowered. And there is also a reduction in the multiple pregnancy rate in women who are undergoing laparoscopic ovarian drilling. So that is a very, very important one that you should know. And next comes, when you're inducing, you have to think of the OHSs. What are the precautions that you're going to take for this PCOS women to prevent the OHSs? You have to identify the high responders. Definitely women who are having a very high antral follicle, who have a high hormonal level, definitely needs to be very careful when you're doing your control ovarian stimulation. We have to titrate the drug very carefully, give them a very proper dosages and carefully monitor them. And if there are very many more cycles of 5 or 6 follicles coming dominantly, you have to either cancel or you have to convert them for an IVF. And also keep in mind about the GnRH agonist as a trigger to prevent the OHSs. Also can be given, so along with that, antagonist, cabergoline, and also all other measurements can be given for the prevention of OHSs. And definitely don't use HCG for the triggering as well as for the luteal support. These are the challenges that you should keep in mind when you are planning for a prevention of OHSs. Also, the latest modalities is only a GnRH antagonist protocol and GnRH agonist triggering and blastocyst transfer or oocyte or embryo vitrification. And that will help you to remove OHSs and give you a OHSs free clinic and prevent a hyperstimulation, which is very common in a PCOS women. So infertility treatment starts with the lifestyle changes and goes with the medical treatment. And mid-occur, you have the laparoscopic drilling as one of the options. And finally, if everything fails, then only comes your IVF. So I just want to tell all the senior people, all the juniors who are watching here, for PCOS, IVF is we come across, because we've been practicing more than 25 years. Initial days of life, we'll be seeing a lot of PCOS coming for the drugs treatment. But nowadays, they are married just 2 years. They have done already IVF, failed IVF, then they come to you. So that is the scenario which is changing. And many of the PCOS patients are getting treated with IVF as the first line. At this juncture, I would like to emphasize, please don't go for the first line treatment as an IVF. That is the last line of treatment when every other thing fails for the PCOS women. So that is a very important thing I want to tell you. So managing an anovulatory infertility in a PCOS women is actually a very important part. Even a global WHO guidance says that always start with the lifestyle changes, and then if needed a weight reduction, which even a bariatric surgery can be helpful, and then the pharmacotherapy, which could be either a clomiphene or an aromatase inhibitor, along with the insulin sensitizers, and then the surgery, and then lastly, if everything fails only, there comes your IVF. So this is a very important flow of fertility challenges that you should keep in your mind when you are treating a IVF. When you're treating a PCOS patient, never put your IVF as the first line of management. With this word, I thank one and all for the patient listening, and I'm open to questions. Thank you.
That was a wonderful introspection into the whole thing, ma'am. You've touched everything. I've got just a couple of questions for you. Suppose you have a young girl who's been coming to us for PCO. Now she comes with her wedding invitation card. So what will we advise her?
So definitely I will advise her to get the pregnancy soon. If she's, first is actually her lifestyle. If she's normal weight, if she has a BMI, good BMI and good thing, ask her to try it, because usually if such patient is there, she would have already got a treatment for an adolescent PCOS with me. If so, I would have treated her, given her a proper counseling about her lifestyle changes, and even I would have given her a myonistal or a metformin to maintain her, and give her a very good advice to get the pregnancy, to never postpone the pregnancy. If at all, if she wants to plan, I will give her an overall, oral OC pills that will give her a better hormonal control and regularize her menses, so that she gets the ovulation very well after a few cycles. So that is a very important thing. If she wants to plan, give her a oral contraceptive for few cycles, so that her ovulation will be better after that, along with the lifestyle modification and other drugs like metformin and
Would you go for direct ovulation induction, or would you ask her to?
No, I will not give her an ovulation induction on the beginning, because sometimes they ovulate themselves, because almost 20 to 30% of the PCOS women, they ovulate with your lifestyle changes and if you are giving them a overall or an OC pill, they will always ovulate themselves. They get ovulation spontaneously. No need for ovulation induction for every PCOS. We can wait and give them a proper counseling.
And one short question that I've got for you. Suppose you have a lady for whom you're planning to do an IUI, and do you have any role for putting her on antagonist during an IUI cycle?
No, that will be the last way. So the basic for a PCOS women, we want to have 1 or 2 proper follicular growth with a good endometrium. That is more than sufficient for an IUI. So we never go for an antagonistic for the PCOS for an IUI cycles. Never we will do it.
Ma'am, how will you manage the LH surge occurring while using the patient with oral ovulogens? Most usually we get LH surge before the follicle reaches some 16 or 16 mm. How will you manage if it is occurring repeatedly?
See, LH surge, why you check in LH surge every time? There's no need. You need not check. Because if you are monitoring your follicular monitoring properly as a single person yourself, you cannot miss a proper ideal pre-ovulatory follicle. If it is you're monitoring her well, you will just find out exactly when she has the pre-ovulatory follicle. At that time, if you trigger her, she will definitely ovulate. If you prematurely trigger her, then only she will go for all your luteinization and other things.
Sometimes we see a follicle in the 14.
I think, Mohana, I think, when the follicles are not good, they sometimes these PCOS patients have a premature LH surge, I think. So, but they are not a good follicle. So we don't need to worry for that. Usha madam said, the girl coming to you with the wedding invitation. I think at that time, the most demanding is the regularization of cycle. She doesn't want to go with a disturbed cycle into her marriage. I think so. They opt out for a good regularization, as Jayarani madam said, for the OCPs.
Why OC pills, ma'am? Why not you have a micronized progesterones to regularize her cycle?
Sometimes they may not even respond, Kundavi, to your micronized progesterones. Sometimes they won't even respond. They need some amount of an estrogen. But sometimes they need an estrogen to work on it. Even your micronized progesterone may not give you a pregnancy. You may not give you a menses also sometimes.
Because there'll be N-ovulatory, so they won't have a good estrogen.
Good estrogen they won't have.
They respond better to the OCPs. Unless she's got a prolonged cycle and you've seen her endometrium, say around 3 months, and you give a withdrawal for 10 days. I think.
Yeah.
This luteinized unruptured follicle, I think we have to measure the prolactin. Most of the times, they could be associated with hyperprolactinemia, which
PSH and prolactin.
Yeah, so that could also. So once we correct that, then in the succeeding cycle, she will not have that.
Yeah.
Maybe endometriosis also do have LUS.
Some additions, PID, all associated factors will not.
And probably CC, if you're giving CC, probably change over to letrozole.
So that was a very nice presentation, madam. Very tough nut to crack, and you cracked it very well. So excellent one. And Sausha Rani madam rightly said it was a very tough nut to crack. Okay. So we move on to the next one. May I hand over the session to Dr. Mohana Pramila, my co-chairperson, to take over the proceedings.
I welcome Dr. Dhanalakshmi ma'am to chair the next session and to introduce Dr. Malaraj ma'am. Dr. Dhanalakshmi ma'am is a professor and a senior consultant, Department of OB/GYN, Srihar, Chennai. She is an eminent teacher and a mentor for many young generation. She is an enthusiastic Auxian And she has conducted many successful conferences and touched our heart. Welcome, Dhanlakshmi ma'am, and I request you to introduce Mala ma'am.
Thank you so much. And let me get Dr. Mala's exhaustive CV. And she's a very dear and sincere EC member of Oxy, and she's a founder secretary for IAG Tamil Nadu chapter. And recently, she had been given the gift of being a proud mother of a Asian champion through her daughter, Dr. Arti. And she's currently managing director of Firm Hospitals. And I'm waiting to hear about this new emerging topic, gut dysbiosis in PCOS. We heard it from eminent speakers in the past, but let us hear from our own friend, Dr. Mala Raj.
Thank you so much, Madam, for the warm introduction. In fact, Dhanlakshmi Madam is such a boon to Oxy, and we are all very fortunate to have her with us. And then it's always a real pleasure to work with Madam, such a tech-savvy person, very prompt and very meticulous, and very systematic in all her works. And thank you so much. I am really blessed to work with you, ma'am. So, now the topic here again is one of the many facets of PCOS. This is the gut dysbiosis, which has been thrown quite a lot of light in the current scenario on the PCOS management. So we all know that PCOS, almost 6 to 20% of the women of the reproductive age are affected. And of course, now there is a recent study which shows that there is a association between the gut microbiome and the metabolic and the clinical parameters of PCOS. And this dysbiosis of the gut microbiota will be a potential pathogenic mechanism for the development of PCOS, and a modification of these gut microbiota with probiotic, prebiotic, symbiotic agents is now the current treatment options of PCOS. So there are various studies which suggest that the insulin resistant, the sex hormone concentration, and the obesity will affect the diversity and the composition of the gut microbiota in women with PCOS. With this brief outing, let me just go into the depth of what exactly this is gut dysbiosis. To understand gut dysbiosis, we should understand what exactly is the gut microbiota. See, normally every human has both good bacteria and the bad bacteria, and they have learned to live in equilibrium. But only when there is an unequilibrium occurring between the good and the bad bacteria, the gut dysbiosis occur, the pathogenic organism overruns the good bacteria, then we have chronic inflammation sets in, and which results in lots of other problematic diseases, not just PCOS, but many other diseases like endometriosis and pregnancy complications, infertility, and other things. But today my focus would be only on PCOS. So we have our female genital tract, which has this natural microbiome, and this natural microbiome is one which we need to treasure, because many times they get washed off because of the outside pathogens entering into our system and changing the entire dynamics of the GIT and the reproductive system. So this microbiota, they play a very major role in reproductive system by interacting with various hormones like the androgens, the estrogens, the insulin, and also the various other hormones. So it is actually now being considered as an endocrine organ to maintain the human health. So the gut microbiota disorder is involved in the production of endotoxins. They produce endotoxemia and small chain fatty acid production, and also they alter the bile acid metabolism. They also cause abnormal secretion of the brain-gut peptides by altering the brain-gut axis. So this results in the poor follicular development. The sex hormone and the metabolic levels are also altered, and also it results in insulin resistance, chronic inflammations, and alters the brain-gut axis. So the normal gut microbiota and the host, they live together in harmony and they are mutually benefited. So they cause a clinical manifestation of PCOS when there is a disharmony through production of the short chain fatty acids by the microbiota and other hormones influencing that. So when we have a good lifestyle, all these are in equilibrium. But when we have an unhealthy lifestyle, there is a reduction of the good bacteria and increase in the bad bacteria. And also they have various studies now done on this gut dysbiosis, wherein on 39 PCOS patients and 40 healthy women, they have found that the vaginal microbiota of the PCOS patients was significantly different from that of the healthy patients. And this was characterized by increase in the diversity and increase in the abundance of mycoplasma and previtella and decrease in the abundance of L. crispatum. This lactobacillus, this is a good bacteria, and you can see that there is an increase in the bad bacteria. So this suggests that vaginal microbiota dysbiosis may participate or contribute to the PCOS pathology. So as long as we have this equilibrium, it will be in the entire system remains in order. So in eubiosis, that is when everything is in order, you have more than 90% of the bacteria will be lactobacillus, bacteroids, and bifidobacterium, and they have a very, very low microbial load. And tissue remodeling, all that will take place, and it has a moderate immune stimulation. But what happens when it goes the other way around? That is when we have less than 90% of the lactobacillus, staphylococcus, enterobacter, what happens? You'll have high microbial load, infection occurs, sets in, and instead of tissue remodeling, tissue destruction starts in, and also it stimulates your immune stimulation and cause immune dysfunction. So this sets the platform for the pathology which occurs in our body. So the gut microbiota is dysbiosis, where what happens is that these bacteria will produce certain toxins which will leak through the mucosa of the intestine and result in metabolic endotoxemia and alter the immune system of the body. And this immune system results in chronic inflammation, which results in insulin resistance and, of course, hyperandrogenemia and PCOS. So that is the reason now we have to understand PCOS. Apart from various other treatment modalities which have been discussed earlier, this problem we need to address at the root level to make sure we are able to give her a long-term outcome. Now, this gut-brain axis plays a very, very vital role. So what exactly is this gut-brain axis? We all know about the HPO axis, but this is something new, the gut-brain axis, which occurs in our PCOS women. Now, the pathological mechanism is not limited to the dysfunction of the HPO axis, but also involves the gut-brain axis. So normally here there is a communication, two-way communication between the nervous system and the gastrointestinal tract. The microbiota which are present in the gut can affect this axis in a variety of ways. Now, the gut microbiota, what it does is it will stimulate the vagus nerve pathway and it will send signals to the brain, similar to that of our HPO axis. Now, this gut-brain axis is an information exchange system between the brain and the intestine. Now, this intestinal bacteria, they will produce the short-chain fatty acids, and they will secrete the brain gut peptides by the intestinal endocrine cells like the ghrelin. The ghrelin, as we all know, is very, very essential to maintain satiety and to prevent obesity. So, but this is the one which interferes with that, and as a result, this kind gets secreted, and as a result, there is a tendency for the women also to develop excess weight gain. This is mainly because of its action on the hypothalamus, resulting in chronic inflammation and insulin resistance. So this is the manner by which the bacteria acts on the nervous system and results in PCOS. So at the same time, if you see, the gut microbiota forms feedback to the brain by synthesizing hormones and neurotransmitters. the intestinal peptides in the systemic circulation, they will bind to the receptors at the end of the vagus nerve, and they will communicate with the brain through these axes. And as I mentioned, it results in the secretion of ghrelin. Now, this ghrelin will inhibit the excessive secretion and release of luteinizing hormone, and which is very, very vital for that of the development of PCOS. That is how the women develop insulin resistance and PCOS. Now, this gut dysbiosis causes so much of chronic inflammation. So PCOS is a chronic inflammatory condition. So a large number of macrophages are present in the periphery of the ovarian tissues, which has been documented. Now, the expression of the inflammatory factors, that is the interleukins, they are the main factors which are responsible for this inflammatory response. So here you can see how in the normal gut, everything is in balance and there is absolutely no inflammation. But here, if you see, when there is more of this bad bacteria, there is so much of inflammation and toxins getting released, and this will only send the signal to the brain and results in the series of events which I had mentioned earlier. Now, this imbalance of the microbiota can lead to inflammation and result to various other diseases, just not about PCOS. It causes various other diseases, as I mentioned, endometriosis, pregnancy complications, and even infertility. That is the reason why we are using all these probiotics even for infertile women, to make sure that we clear the environment for them just before we transfer the embryos. Now, this is how exactly is the system functioning when they have so much of dysbiosis, reduction of the good bacteria, that is a lactobacillus, and increase in all the other pathogenic ones, that is the Gardnerella, and as a result you have this all the inflammatory markers which keeps going up. So a large number of macrophages, if you see, have been seen infiltrating on the ovarian tissues, and these inflammatory markers also are in varying degree depending upon the PCOS status of the women. So ghrelin, this is a very, very important hormone. It is an endocrine hormone secreted by the intestine, and this can inhibit the excessive secretion and release of LH. This is altered in the brain-gut axis, and as a result, you get insulin resistance. So this is a study where they have shown that the elevated plasma level of tumor necrosing factor, interleukins, among PCOS women, and which reflect the chronic inflammations. This is a chronic inflammations because of the varied lifestyle and obesity, and resulting in, of course, a poor reproductive outcome. So what exactly is this leaky gut? So when we have this pathogenic organism in our system and there is an imbalance in the environment, these organisms will release a substance which could affect the intestinal barrier. They cause a dysfunction of the intestinal barrier, and as a result, this results in a leaky gut. So these are the bacteroids, E. coli, which are gram-negative bacteria, which are now getting dormant. And the LPS is a very important component of the cell wall of the gram-negative bacteria. So with intestinal injury, this LPS is what is entering into the circulation, blood circulation, and forming toxins. That is, it results in endotoxemia. So through this LPS binding protein, that is the CD14 and the bone marrow differentiation factor, this LPS is recognized and it is bound by all these inflammatory markers. So this is how exactly it occurs. So you have the pathogenic organism which is releasing the LPS. Now this LPS is destroying the mucosal barrier in the intestine. So what happens? The toxin now is entering into the blood circulation. Now this enters into the circulation, and as a result, it causes various reproductive dysfunctions, right from the menstrual cycle to the quality of the oocytes to fertilization to even in pregnancy complications like including placentations, and of course into the newborn. So LPS can induce this inflammatory marker. So once we arrest this, the problem gets solved. So gut dysbiosis also produces hyperandrogenism. So this is, they have found that the mice, they have found it in animals, that is they have injected, that is mice with dihydrotestosterone, and they have found that there is an increased number of chlamydia, but there is a decrease in the number of E. coli and affected body mass and fat mass, suggesting that the gut microbiota may be related to the level of hyperandrogenism in mice. So PCOS-induced mice have increased number of all these things. So gut microbiota and hyperandrogenism plays a very, very vital role. So we need to take care of the gut microbiota to reduce the androgen level. So apart from that, increasing the dietary fiber, oral butyrate supplements, and all these can also prevent obesity and improve the insulin sensitivity, and the imbalance of the gut microbiota can also change the short chain fatty acids and improve the insulin resistance. So it has also been compared, that is the gut microbiota of the PCOS patients with insulin resistance with that of the healthy control group, and they found that there is an abundance of Prevotella, which is decreased, and Bacteroides is increased, and the gut microbiota, they affect the bile acid metabolism. So because it affects the bile acid metabolism, the sex binding hormone, binding globulin hormone is also affected, and as a result, you will have insulin resistance. So how are we going to manage the dysbiosis? So apart from treating all other facets of PCOS, we have to now pay attention to this gut microbiota to have a successful outcome for whatever pathology we are treating. So to achieve that, we have various various agents. We have prebiotic, we have probiotic. The current thing, which is though experimental, is that fecal microbiota transplant and herbal medicines. So these probiotics and prebiotics. Probiotics are what everyone is familiar about. They are the good bacteria which is there in our systems, and we need to feed our body these bacteria so that it will correct the imbalance in the intestine. Whereas the prebiotics are the alpha-lactalbumin. So it has been found that a recent study, that is 7 out of 10 probiotic products, there will be a significant reduction in the bacterial strains due to the gastric environment. So it is just not about giving probiotic. We should also make sure that the probiotic works. So the focus on the research has now been shifted to the prebiotic molecules. For example, the protein like alpha-lactalbumin, which is essential for recovery and maintaining the intestinal eubiosis. So what exactly this probiotic does is that it will maintain the intestinal wall permeability, so that there is no leaking of the gut, and the good bacteria is restored inside the intestine. So this prebiotic acts along with the probiotic and helps to maintain the environment. So it has got antibacterial action, and it controls the establishment of the correct intestinal flora, thereby preventing the dysbiosis. So it promotes the growth of the good bacteria. So as a result, we need to have a balance of this lactoferrin, which is a prebiotic, and lactobacillus, which is a probiotic. So both should work in harmony so that we are able to achieve a good environment, that is a good, which this provides a good nutriting factor for the other factors which are present in the intestine. And also they are actually a carrier. So this carries, the prebiotic carries the good effect to the probiotic. So both works together to give a good environment. So this lactoferrin helps in the immunological properties of the intestine, and it promotes the growth and diversity of the intestinal microbiota, so that the microbiota are good microbiome are maintained inside the intestine. So here this is what is exactly being depicted, where you can see how during inflammations there is an imbalance, and then the normal vagina having a balance of both pre and the probiotics. So lactoferrin and lactobacillus is what is now considered as a first defense line mechanism for the female mucosal genital tract. And this is involved in protecting against lots of infections, and it is the most effective and natural mechanism to calm down the inflammation, to dampen the inflammatory process of the body. So both together can inhibit the adhesion and consequently the microbial entry inside the cells, and appear complementary since lactobacilli inhibit the microbial intracellular replication, and together with the lactoferrin, it hinders the infection of healthy cells. So this close cooperation is also exerted through their anti-inflammatory function. So the crux is mainly to combine this in our treatment protocol to treat PCOS in total. So we have to give a symbiotic approach to PCOS patients by using these two prebiotics and the probiotics, so that we will get a bacterial LPS inside. You have a good bacterial colonization inside the intestine, and you will be able to correct all the problems associated with PCOS along with the other therapies. So this is one which is on research, where they have found that the fecal microbiota transplantation is very found to be quite effective in the treatment of inflammatory bowel disease. So the fecal microbiota transplantation is widely believed to be transplantation of feces from healthy individuals to the intestinal tract of the patients, so as to achieve the purpose of treating diseases by improving and rebuilding the gut microbiota. Of course, this is what is in the research process for improving the microbiota. And apart from that, herbal medicines, some Chinese herbal medicines and the active ingredients have also been found to be useful for PCOS for a long time. And these herbal medicines and the ingredients, they also seem to be having a good ability to regulate the gut microbiota. So to conclude, there are complex and close interactions between PCOS and the gut microbiota, and the current therapy in the PCOS aims at correcting the gut dysbiosis, so that we are able to treat the complex PCOS in toto and get a good outcome for our patients. So thank you so much for your patient listening, and I would be happy to take in.
It was a wonderful lecture, a new topic, but biosis, you made it so simple that we were able to grasp the crust of your lecture. Thank you, Mala. And no questions in the chat box, but it's open to discussion.
Yeah, thank you so much, madam.
It was a nice topic, Mala.
Yeah, thank you, ma'am.
But then how do we know whether the polycystic ovary metabolic changes are the cause for the altered microbes?
And I think empirically we have to treat, ma'am, for all PCOS, we have to also treat the dysbiosis, because most of the time they will be associated with what the studies are coming up now. So apart from other treatment like insulin resistance, the sensitizers what we are giving, we have to also add these, microbiota in our thing. That is why we are now, so much of other, Upcord and other things are there in the market now, which has all these lactobacillus also added. We are assuming that because of this chronic inflammation, there can be a disturbance, and empirically we are treating them. So of course, it is very difficult to find out whether there is an imbalance or not. I don't think so there is any valid test to find that out, but then empirically we have to treat is what I could infer out of this preparation process.
A lot of studies were offered. People wanted to have some collaboration to study about all this.
Okay, madam.
Gut microbiota. So I was really a little skeptic whether it's going to be one more of like this, innumerable that is being offered for.
Yeah, somebody is doing a study on ghrelin.
Infertility.
Also, okay.
Ghrelin.
Okay.
I think Dr. Amidevi Tirnakarsu madam was doing some research on gut dysbiosis. She presented her research midway observations in the last lecture which we invited. So I think more light will get thrown on it
That
once
is
we get more
associated with
studies.
obesity, no, madam. So obesity, insulin resistant, PCOS is girly. So, and this one enhances that. So that is what we could understand out of the whole thing.
As of now, we'll go like it is an empirical treatment till we get a solid recommendation to use it as a routine for PCOS patients. And when we should have a test to prove that they have dysbiosis, and we should have a drug which can counter this dysbiosis. Till such time, we're going for empirical treatment.
Yeah.
And Chitrakala?
Yes, ma'am. Yeah. Thank you.
Now from dysbiosis to style the lifestyle of PCOS, I invite Dr. Ritu Khanna ma'am. I invite Dr. Shanti Gunasingh ma'am to chair this session and introduce Dr. Ritu Khanna ma'am. Dr. Shanti Gunasingh ma'am is a consultant OB/GYN. She's a past president of OXY. Madam was a former director and superintendent of Institute of Obs and Gynae. And Madam has a special interest in academics, and she is an eminent teacher. And she was my chief when I worked as an assistant professor in KMC, and we had a very good association. And Madam was a very good guide for the juniors.
Very active president of Chennai Menopause Society.
Yeah. She's always inspiring the juniors to take part in all academic activities. Welcome, ma'am, for the.
Thank you, Mohana Pramila, for your wonderful welcome. Now I call upon, we all know that lifestyle modification is the sheet anchor for management of PCOS. All of us know about that diet, exercise and behavioral therapy. And so I invite Dr. Ritu Khanna to talk about that. She is Director Khanna Medical Center Fertility Clinic Varanasi, a fertility specialist and endoscopic surgeon, and she has been the chairperson of Oxy Food and Drug Medico-Surgical Equipment Committee 2021 to 24, Secretary Society of Fetal Medicine UP Chapter 2021 to 24. She has held a lot of positions in UP COG and was the Scientific Secretary IMS Varanasi Chapter 2020 to 21. She is working on exclusive single embryo transfer and has received a lot of awards like Dr. B.C. Roy Memorial Award for Outstanding Contribution in OG and Presidential Award 2021 by IMA Banaras, and has published a lot of papers. She is a very excellent orator. Always it's a pleasure to listen to Dr. Ritu Khanna. Dr. Ritu Khanna.
Thank you so much for those kind and loving words, Shanti Madam. And first of all, my thanks to the dynamic team of Oxy, Dr. President, Dr. Jayarani Madam, and the Secretary, Dr. Kundavi Madam, for having, and Dr. Malaraj for having me here on this platform today. And it's always a pleasure to be here. And I think this evening, and also my regards to Pushpa Madam, Mridubhashini Madam, and Usha Rani Madam, and Dhanalakshmi Madam, and my regards also to the chairpersons. So thank you at the outset. And with this, I think we are on the last talk, but this is the most important what I feel. And we're talking the whole evening about PCOS because we know it's the most common endocrinological disorder and 70% of them remain undiagnosed. But we need to know so much of difference in ethnicity, environment, nutrition, and genetics. So if we look into the population, the Caucasians and the Indian women, just look at the incidence. It's just 6.5 in Caucasians, and Indian, it's 9 to 36%. And when you look at the age group, the South Asians with PCOS are presenting at a younger age group. And the Indian PCOS women have a higher risk of developing gestational diabetes as compared to the Caucasians. It's 16:1. That means that all the non-Caucasian women regardless of any of their BMI or anything, should have an oral glucose tolerance done because they opt out to be a greater, higher insulin resistance. So the etiology, as Mridubhashini Madam said, is very, very complex. And today they say that it's genes in the environment which creates a phenotype. So it's a two-hit scenario. The first hit was a congenital predisposition, like a suboptimal fetal nutrition or a heritable genetic variants related to insulin, steroidogenesis in ovarian. And the second was a postnatal hit, and it's insulin-resistant hyperinsulinemia, like those which are seen with the metabolic syndrome and the obesity. So after we had the Rotterdam criteria to bring us the diagnosis, the NIH group, evidence-based methodology workshop, said, you put these PCOS into the different types, and these different types were graded, into type A, B, C, or D, depending on the hyperandrogenemia or the ovulatory or the ultrasound. If they had all three, they were the classic. If they had hyperandrogenemia and the ovulatory, they were B. So why did we do it? We need to take care of some patients much, and some need less care. So those who fell into the type A and B had a higher risk of any of the metabolic risks and reproductive risks. So we need to take care of these patients. And we also know that it's a vicious cycle. We have the resistance, we have the hyperinsulinemia, altered fat metabolism, and lipid storage. So that is again leading to obesity, and the cycle goes on. And we had all these presentations. But what happened was that 50% of the affected women are either overweight or they're obese. But studies said that they demonstrated a greater visceral fat tissue rather than a BMI. So why was this? Because this adipose tissue acts like an endocrine organ. The leptin are the higher levels which reduce androgen to estrogen conversion, and the adiponectin lower levels reduce the insulin sensitivity. Not only this, it's an endocrine modulator. So the major conversions, androgen to estrogen and the cortisol to cortisol, and therefore there was a reason that we had all these presentations. We used to consider BMI. We classify her, she's an overweight, she's an obese. But BMI has got limitations. So today we take as the waist circumference to the hip ratio as the criteria where we have an apple or a pear shaped. And this hip waist to hip, because if it goes more than 88 centimeters, it's significant. Why? Because it correlates more with obesity risk. And it's more of a visceral tissue, which is important. Just look at the CT scan, the black area that corresponds to the visceral adipose tissue. But why is it important for us? It's because it is this which correlates with the total androgen level. So a cause for an adipose dysfunction, an accumulation, and increased insulin resistance. So that means today, the central player is the insulin resistance, and our goal has to rest on managing this part. Therefore, lifestyle. This lifestyle is not only diet, but it's a combination of diet and physical activity, which we really need to manage with other interventions. So we take her as a regular exercise and a healthy diet. So the first and the foremost, they need to stop smoking, limit alcohol and caffeine. And what is the reason? Because it lowers estrogen level and increases the DHA and androgen level. So this needs to take care of. Now we tell her, you restrict your calories. But how exactly do we calculate these calories? For calculating, we need to know what is our activity. Are we sedentary workers? Are we moderate? Are we active? But how do we know we are a sedentary worker? Sedentary is something when you're just carrying out your activities of a daily living. Now, if you walk 1.5 to 3 miles per day, then you are a moderate. And if you walk more than 3.5 miles per day, you're an active worker. So that places you into this chart, and that's how you calculate your calories according to your age and your activity level. And that starts the recommended calories intake for all the lean PCOS patients also. The second thing is we need to do an energy deficit. So a daily deficit of around 200 calories. If we do it, what is it going to matter? It's going to prevent your weight gain and promote your weight loss in the longer term. Now, if you want to decrease 0.5, you need to have a deficit of 500 kilocalories per day. If you want to decrease 1 kg per week, then you need to have a deficit of 1000 kilocalories. Now, if you go for the physical activity, the different types, what about a obese PCOS? What about a lean PCOS? So the different exercises could be an aerobic or a resistance activities, and I'll come to it, how we need to advise the exercise. Now we need to limit our exercises or categorize into light, moderate, or vigorous. Now, what are these light exercises? Light exercises are the aerobic that does not cause noticeable changes in any of your breathing rates. So that means a casual walking, a cycling less than 8 kilometers, just a stretching, a lightweight training, or just dancing very slowly is something which is light. So your aerobic activity that is conducted while you're doing an uninterrupted conversation is called as a moderate, and that's a brisk walking. It's a walking uphill or hiking or cycling more than 8 to 15 kilometers. So that is a moderate. And a vigorous activity is an aerobic where an uninterrupted conversation, generally you can't maintain that. So that means you're going to do a race walking, you're doing a jumping or a jogging or a mount climbing, and that's what is moderate. So what exactly you need to do? If it's an adult from 18 to 64 years, you need a minimum of 150 minutes per week of a moderate or a 75 minutes of a vigorous activity. And if it's an adolescent, you need 60 minutes of moderate to vigorous exercises and per day. So when you just calculate, tell me how many steps should I walk? You know, I'm doing this much of housework, I'm doing this much of walking, I'm doing 6 much of cycling. So it's approximately 10,000 steps is ideal. Activity, which includes daily living, your 30 minutes of structured exercise, and everything should include in this 10,000 steps. So as Jairani Madam said, it has to be specific, measurable, achievable, relevant, and time limited. But how you start? It's just a 10 minutes bounce. And then you go on increasing this activity by 5% weekly. And so is that you go. But what happens when you do an exercise? When you're doing an exercise, you know, it relieves all your stress. It burns calories. It strengthens the immune system and helps you thereby to lose your weight and keeps you alive. Now, if somebody says, put a prescription for an exercise, I would write it as FIT VP. FIT is frequency 5 days a week, intensity moderate, type is an aerobic, and time is 30 minutes per day. And yes, you need to walk 150 minutes per week, moderate, and progress. That means start slow and start low and go slow. So that would be a prescription. But why were we doing this exercise? Because this exercise is going to release the happy hormones. So whenever there's an infertility or anything which acne, hirsutism, it's a real anxiety and a stress. So this exercise, releasing happy hormones, is going to take care of this. So how do you plan your exercise? You know, your life activity is just not a formal. Just plan it with your partners, with your friends, with your families. Now, if you're doing, let's calculate, you know, if you're just doing a home activity, you're going to burn 3 calories per minute. If you walk, it's 4 calories. If you jog, it's 6. And if you run, it's 8. And you walk up the stairs, it's just 10 kilocalories. So what would we like to do? We're going to put off all our lift systems and start walking. And that's the best thing I think we can do. So apart from this, there's so many Surya Namaskar and everything that is going to improve your body and mind and going to put you much more effective to all your medications. Yes, you need to create a negative energy balance. And that's what we talked about, that how much you need to decrease to get a negative energy balance. Now, if you do 10%, it's fantastic. But don't worry, even if there's a 5% reduction, it's going to improve your glucose dynamics. And 60% had a return of the menstrual cycle, along with the decrease in the insulin resistance and the androgen level. And there's so many studies that so many patients ovulated and they became pregnant. So they have a good effect. But what about the lean PCOS? Do they need to do the same exercises? Now, the lean PCOS need to have some resistance exercise to bolster your weight management efforts. So this is done by slowly increasing the weight lifting, repetitions of these exercises, because they're going to help you to decrease the visceral fat and increase your lean muscle mass. And that's how they're going to decrease the elevated androgen levels or the insulin resistance. Now for PCOS, the diet, the planning is a must. I think with the clocks, they need to put the timing into the clocks. And this will show you that at 9, 11, 1, 4, and 8, I need to move like this. It's very, very important. And you need to put how much of carbohydrates at 400 to 450. You should have fats, of 25 grams, and iron 21, protein 50, 55, and of course, sodium and calcium need to be added. But experiments are that they need to be regular. They need to take their diet on time, because if they consume a breakfast, the energy intake would be lower and they improve on the insulin sensitivity. So it was found by the studies that if they saw that if they do 2 weeks of irregular eating, or they're going to omit the breakfast, what is going to happen? It's going to lead to your more increased weight and development of obesity. The American Heart Institute said that the frequency and the timing are very, very important parameters if you want to manage any chronic disease. And we know that PCOS is a chronic inflammatory disease. Now, insulin resistance will cause high blood sugar levels. So which can raise your appetite, can cause you craving for sweets, and that's how your weight gain is going to. So what are you going to do? You're going to take something or the other at 4 to 5 hours interval. Skipping meals means you're going to overeat later. And if you overeat, it's going to cause a lot of swings in your insulin and blood sugar levels. So what do? You plan 3 meals and 2 snacks. So what do you do in these meals? You add 3 food groups, and in your snacks, you take 2 food groups. So eat smaller meals and snacks throughout the day. So this is going to blunt the insulin response and avoid the feeling of getting over hungry and eating much more. Now, all the blood glucose and insulin levels, they go hand in hand. The more blood glucose, the more insulin is going to secrete it, and therefore you need to cut on the carbohydrates. So it's 25 to 30% of the plate, which was 50%. And what you need to take is don't go in for juices. Do go in for the whole fruits. And why? Because whole grains instead of the processed ones, because they're going to help you to reduce the insulin demands. And eating too much of carbohydrate, sugar, again, inflammation, and the inflammation is going to let these ovaries to produce more androgens. So what you need to consume are the low glycemic index foods. Why? Because they'll have a slower digestion, they're going to be absorbed slowly, so your rise in blood glucose will be less. So you consume a lot of broccoli, cauliflower, bell peppers, carrots, beans, lentils, and anti-inflammatory foods. We're just hearing, about the gut dysbiosis. So tomatoes, spinach, nut almonds, olive oil, all the anti-inflammatory need to be consumed. Now, if I tell you how much of, we're sitting on a table, how much of carbohydrates or something do I put up? Just open up your palm, and the palm is your proteins. If you just cup your palm, it becomes this much of starch you need to take. If you close your fist, that is the vegetable that you need to take. If you open your thumb, and that's only the fat or the oil that you need to take. So that's how you find out that how much of this should I need to take. So small short meals, but when you get up, consume your breakfast within 1 to 2 hours of waiting, because during sleeping, your body is in a fasting state and there's a poor glucose metabolism. Now, if you're going to prolong this, there'll be poor metabolism of glucose, and that's what will cause your weight gain. So within 1 to 2 hours of waking, take your breakfast, take a snack 2 to 3 hours later, take lunch 2 hours later, take another snack 2 to 3, and a dinner 2 hours later. Lot of leafy vegetables, focus on whole foods, take so many anti-inflammatory turmeric, cinnamon, and fenugreek, because they're going to help you to fight with the insulin resistance. Lot of fruits, lot of vegetables. I said whole grains, whole grain breads, cereals, brown rice, and whole wheat pasta. Take a lot of dietary fiber, at least 25 to 30 grams. Why? Because it's going to prevent constipation, and this is going to allow your body to eliminate all the toxins, decrease the cholesterol, and reduce all your insulin spikes. The fiber is not digestible easily. So it's going to cause a very slow digestion, and subsequently what is going to happen is there's going to be a slow release of glucose in the body and blunting the insulin response. So also to modulate the gut microbiota dysbiosis, there's a growth of the fiber biofida bacteria, which correlates with the insulin secretion and the increased glucose tolerance. And this is going to help to reduce your inflammation. So food selection, you're going to prepare the portion, the size, the timing, everything you need to adjust. And this is now what your pyramid stands off. You have a base of a good grains and vegetables, and then comes the milk, feed, and meat and fish and egg, and a small amount of your fats and the oils which lie at the top. So you take small amounts of the unprocessed carbohydrates along with the lean protein and a little fat. But this is going to increase the satiety and hold the blood sugar steadily. So it's going to avoid glucose dips that can trigger your carbohydrate carvings. And you need to take the healthy fats. And this is the healthy fat food like avocado, salmon, mackerel, sardines, butter, and oil. And these increasing this small amount of fats is going to keep you satiated and help your body to absorb the vitamins of A, D, E, and K. So you need to limit your saturated fat intake to less than 10% of your total calories. Cheese, red meats, butter, margarine, and chatting. So avoid all the trans fats and hydrogenated fats. So we had something, like a DASH diet, a moderately low carbohydrate diet. What was it exactly? It was an alternative, that you take small meals, you take 5 to 6 meals, you consume them at a regular time, and majority of the carbohydrate should be taken at lunchtime. And if you cannot do that, equally distribute the carbohydrate throughout the day. And that is a first line, which was for the management of PCOS also, and the insulin. Never miss your sleep. Just take your proper sleep, because if your sleep is interrupted or it is something, not able to sleep well, it's going to lead to more food carvings and your changes in appetite. And you really, really do not want that. Yes, today is an emerging concept of micronutrients. So include omega-3 fatty acids and of course, vitamin D also. The B2, B3, B5, B6 have a critical role, and calcium important for the egg maturation and follicle development in these patients who have a bad follicles that we get. A very important factor which still needs to be unaddressed is in obese PCOS, there is a PAPA or delta receptor. It is a peroxisome proliferative activated receptor. So there are 3 types of receptors, alpha, gamma, and delta, which are responsible. Alpha is to reduce triglyceride, and the gamma causes insulin sensitization, and the delta is one which enhances the fatty acid metabolism. So there are 3 distinct forms, but they're expressed in the adipose tissue, in the skeletal muscle, in the liver, and the skin. And we are worried about the obese PCOS because of the metabolic syndrome that they carry. So what happens is this PAPA or delta receptor, it cannot act unless it is activated. Once it is activated, it is going to increase the thermogenesis in the adipose tissue. Therefore, your fatty acid catabolism increases and your increased fatty acid transport. So it's going to redirect all the fatty acid towards the skeletal muscle. Your adipose mass is decreasing and it takes care of your weight control. But what is the activator? The activator is vitamin D, and this regulates it. And therefore, this process works. So the vitamin D, when you measure this in PCOS patient, you'll find that there's a much more urinary excretion of these vitamin D in these patients. So once you give, this receptor gets activated, and there's wonderful work in reducing this obesity in these patients. So with high BMI, with hypertension, with hypertriglyceridemia, and lower HDL, you need to supplement these patients also with vitamin D. But when you're going along telling them about diet and diet and diet, it's sometime you need to take into the food preferences to tailor their dietary changes and not restricting them with anything. And a lot of time, these patients have got a lot of behavioral problems and abnormal eating pattern, and they go into depression. So along with your diet and lifestyle, we need to do some behavioral strategies, and that has to be a main aim, and it has to be a goal setting, self-monitoring, stimulus control, and a problem solving to these patients. Stress, yes, we need to decrease. And why is it so? The small short-term stresses are not important, but what is important is a long-term stress. because long time period of time, our adrenal glands secrete more of hormone cortisol, and this makes our other hormones like insulin, leptin, ghrelin, and androgen hormones to go haywire and affecting, as we said, the infertility and the menstrual cycle. So practice yoga, pranayama, exercise, and it releases the neurotransmitters, endorphins, and be exposed to the morning sunlight, and that's going to be increasing our dopamine receptors. So what are the principles? Control macronutrient intake, low calories, low carbohydrates. Don't restrict on your proteins. It should be a low fat, it should be a high fiber, and of course, yes, adequate intake and increasing micronutrients intake also. So many methods of cooking. You're going to steam, you're going to boil, you're going to do pressure cooking, but don't do any amount of frying. Keep it at a lesser level. And your portion size decides your food. The calorie content of food depends on your taste enhancers, you know, the corn flour, salad dressings you like, so much of paneer and everything sprinkled on the salad. So don't do that, avoid that, and creams. So avoid simple sugars, carbonated beverages, bakery products, fried food, fast foods, and excess coconut preparations also. So, but infertility and hirsutism just stand at the tip of the iceberg. And all the cardiometabolic risks take a major toll. So much of metabolic derangements and all these PCOS need to be under a lot of monitoring, their blood pressure annually, and of course, screening if they have cardiovascular risks, including obesity, cigarette smoking, hypertension impaired. Women with PCOS should be considered all these that, yes, they stand at a high risk for cardiovascular disease. So it's a changing paradigm. It's no longer a reproductive disorder. It's a metabolic disease. So we need to do a multidisciplinary approach to manage this condition. So exercise, diet, sleep, friends and families you need, work and relaxation is the crux to manage our PCOS patient. So she says, I'm very strong, I'm beautiful, and I'm enough. So we need to keep carving the life of this PCOS right from the adolescent to the menopause also, I think. And every day is a fight. But she says, I'm never going to give up. And so are we. So thank you so much for a very patient hearing.
Thank you, Dr. Ritu Khanna, for your excellent talk. And you have nicely stressed on the various aspects of lifestyle modifications like diet, exercise, sleep, micronutrients with stress on vitamin D, and of course, to have a stress-free life. It was a very comprehensive and lucid presentation. Thank you very much.
Thank you so much, bye.
That was
I
very
have a
lovely,
question.
Ritu. It was really entertaining. You've given a lot of inputs about the adipose tissue, which is really very good, interesting, thought-provoking things. A very newer way of knowing about fat and the
Thank
diet
you.
and the fat.
Yeah.
Thank you so much. The lifestyle in PCOS was really delivered in style, ma'am. Yes, phenomenal. I was really admiring, and the content was rich. Thank you so much for being part of our webinar.
Thank you. Thank you so much.
It was a very nice talk, ma'am. I have a question for you. Nowadays, people are talking about intermittent fasting because we need to lower the insulin level. And it
So at this time, I think a lot of, dietitians, lot of endocrinologists are advising intermittent fasting, and I think it works well. They take all that, everything, all their meals, they take it before, it's 8 o'clock or 7 o'clock, they take these meals. So I think that works quite well.
Yeah, because insulin secretion also follows the sun, and intermittent fasting also follows the sun. So that's the reason why both are interlinked and have really a beneficial.
Regarding the protein, the vegetarians, they have a lesser options for protein, though we say paneer and we lack
You can take a lot of soyabeans and lot of soyabeans and groundnuts, then all those chana, they can have soaked or roasted chanas and everything. So we need to paneer and dairy products and all. The only stress was that we don't need to cut on the proteins with the PCOS patients. So that's why I said if you put your hand, your palm is a protein. How do we estimate, how much of protein we need to pick up from this and how much of starch we need to take? So that was a simple way of calculating how much can I eat from this table and these bowls which have been put in front of me.
That's excellent. So if there are no more questions, can we call it a day? Yeah, thank you so much. Thank you so much, everyone. I would like to first thank Dr. Jayarani Kamraj Madam and Oxy for giving us this wonderful opportunity and making Oxy Endocrinology Committee to conduct this excellent webinar. The speakers were all phenomenal and excellent and very informative and very useful for practice as well. I would like to thank Dr. Mridubhashini Madam, Dr. Jayarani Madam, Dr. Ritukana Madam for their contribution of knowledge to this meeting. I'm sure everyone would have benefited out of it. And sincere thanks to our eminent chairpersons, Dr. Pushpalata Madam, Dr. Isharani Madam, Dr. Dhanlakshmi Madam, and Dr. Shanti Gunasingh Madam, and our junior colleagues, Dr. Shiva, Dr. Sharanya, Dr. Roshni, and my co-chairperson, Dr. Mohan Premila, for shouldering my responsibility as well. Last but not the least, I would like to thank Shield Pharma for this academic platform, and without their support, this wouldn't have been possible. Thank you so much, Mr. Balaji, and his team, Chitrakala and Sahiti, for this excellent seamless transmission of the webinar. So with this, we come to the end of the session, and thank you once again to everybody who has participated. And I'll also thank the delegates. I think we had a very good number who have been watching this entire webinar, and thank you so much, everyone. Good night.
Thank you, madam. Thank you.
Good night. Thank you.
Mala, Jayarani Madam.
Thank you, Ritu Madam. Thank you, Pushpalata Madam. Thank you.
Thank you. Bye.
Thanks a lot, madam. Thank you.
Thank you so much.